is I'm going to talk about the role that national data and surveys can play in policy brief development. And let me give you a roadmap of my talk. I'm going to keep it quite short, my talk, and then I want to end my talk asking you questions, and we all stay together, asking you questions, and then discuss a few options, a few possibilities that you recognize in your own practice where national data and surveys might be able to help and support developing policy briefs, and also talk through how that would work, what its role could be, what the challenges are, so that we all together can learn and see a few diverse examples. But to do that, I'm going to talk a little bit more about what I see is the role of these national data sets and national surveys are. So where it can be used, how and what data sets there are. I'm going to talk about epidemiology as a key underlying discipline. I'm going to talk a little bit about data science, and then I'm going to give you an example based on a real issue here in England, in the UK, around people's concern about inequalities in outcomes of mothers giving birth in National Health Service hospitals. So that's what I'm going to do. First, a bit of scene setting, epidemiology, a little bit of an example, and then I would like to talk with you about where you see that national data sets and surveys can go. So let me go to the next slide. In terms of where national surveys can play a role, I'll still like to use the knowledge translation map that came about 20 years ago, demonstrating that if you want to go from evidence to knowledge and implementation, you have to think about maybe about 2 steps. First, generate the knowledge and the insight that you require, and then a whole process of implementation. And I always use this map to highlight that there are especially 2 steps when national data and survey data come about. And that's also steps that I'm interested in, because I'm an epidemiologist. I work at the London School of Hygiene and Tropical Medicine. And my background, my discipline is healthcare performance assessment using epidemiological methods. So I'm trying to really understand where these national data sets come in and where they can play a role, but also realizing, and I'm echoing Dr. Colvin's remarks yesterday, that you have different types of data that can support these different elements in this whole integrated knowledge translation approach. So national data, in my practice, play especially a role in trying to understand better the use of knowledge. In other words, sometimes really simplify to in what treatments patients or people get, or what public health measures are being put in place, and the outcomes of these treatments and public health measures. So it's all about understanding differences in process and outcome in this whole process of linked steps where different approaches are necessary. So this is about where national data and surveys can use. And I derived this graph from a paper that some of you may have seen in the past. And then thinking about the role that national data and surveys can play, I'll borrow this. This is from the same set of authors, where they didn't only think about where in the process national data sets and surveys can play a role, but also what national surveys and data can do. And then they highlighted that there is, especially in terms of the use of knowledge, a role to think about that these kind of data can really look at changes in behavior, changes in practice, or you could take one step back, look at practice or behavior in the first place, let alone the changes. And also that this whole large scale use of national data can help us to understand outcomes. So basically, constantly it's about being aware of where and how these large national data sets and surveys producing large national data can be used. And again, it's always most useful to put things into context and to have an awareness of that different sources of data and different methodological approaches are necessary to create an integrated approach. And this table, this systematic thinking comes from this paper. And then I think the next step is, of course, to think about what are we actually talking about if we speak about national data and surveys. And I always try to highlight people that it can be quite a lot of different things. And I've tried to capture that here as well as I can in a number of, what I would call dichotomies. For example, national data and surveys could cover all patients. For instance, in England, we have a data set that's called the hospital episode statistics that captures all patients admitted to the National Health Service hospital. But you have also data sets, for instance, covering only cancer patients, or data set that covers only patients with congenital abnormalities, or captures women who give birth. So it could be all patients or specific groups. That is important to realize. You have to think about the purpose of the data. Why was the data collected? Lots of data that I use in my practice for healthcare performance assessment as an epidemiologist is not collected for that particular purpose. It's collected to support the administration of, for instance, the National Health Service. It's for reimbursements, for payments, or it is for thinking about where, for example, the service needs to grow, or where there are inefficiencies in the way systems are organized. Sometimes the purpose is really for clinical data. We have a cancer registration service in England that collects data really to support and inform the clinical care that patients get. Another important element that I think you need to be aware of, because all these different aspects have an impact on the type of data that you end up with and have to analyze, is how data is collected. Very often nowadays, we move towards data that is routinely collected. For instance, the administrative data to support the management of the NHS is routinely collected. It happens automatically. It's part of caring for patients that some data about them is being collected. But sometimes you want to go further, and you want to get specific things out at national level, and then you have to create what I would call a dedicated survey. You have to collect data yourselves. For instance, if you're interested in patients who get a particular operation in England, for the last couple of years, there is a survey being done to look at how patients are doing if they get a hip replacement, for example. Then you need to organize that separately, because that's not routinely collected. And that's important to realize, because routinely collected data can go on for a long time. It's relatively cheap, it's easier to use, but comes, of course, with some problems, because it only collects data for a particular purpose. And if you use it for a healthcare performance assessment or for a particular aspect of informing a policy brief development, the data might not be particularly collected for that purpose. Whereas dedicated surveys may be, especially set in place to collect the data that you really need. But there's a whole organizational issue around that need to be set up only for that particular purpose. It is sometimes very difficult to see the wider perspective of the information that you have. So you have to think about what is the right type of data, and to what extent you can rely on what's already there, and to what extent you have to decide that you want data collected for the particular type of problem that you face. Timelines play a big role as well. And then the source of data. Sometimes you have clinicians that help you to report data, and clinicians that in the wider sense, that could midwives, nurses, simply healthcare workers. Sometimes we ask patients. Patients could play a role. For instance, that hip replacement example that I mentioned, patients report their own outcomes and also report, for instance, whether they have other comorbidities. And sometimes laboratory data is being used to populate this data, which is more measures and particular values. very interesting, I also think, is about the scope. We mainly, my team mainly uses, for instance, health data, but more and more we bring in non-health data. For example, over the last couple of years, we've looked at outcomes of children with congenital malformations, for instance, a cleft lip and palate, how they do at school. And we have now data of the health service linked with data of school performance at national level, so that you can see to what extent congenital abnormalities, children with congenital abnormalities and the care they get influence or have different outcomes at school, have different educational outcomes than their peers without these abnormalities or without these specific treatments. The complexity of the data plays a role. It could be what I call a single episode. For example, the NHS, the National Health Service here in England, collects data about women giving birth. And you could say, well, that's a single episode. That is the birth episode. We know lots about the women, we know lots about the baby, and that's it. Or it could be longitudinal. For instance, if you want to study care for cancer patients, then a single episode database is not that helpful, because you have to find out what treatment patients get, to what extent they got side effects of the treatment, and then also to what extent cancer recurs and how long these patients live. So the complexity of that data set, I think, is something that is determined by the particular kind of issue that you study, and at the same time it also determines how difficult it will be to handle that data. And more we also move away from a single source, and we use data that is linked at patient level. For example, data for that single episode, for example, of women giving birth, could be linked with their entire hospital records, with all the other episodes they had before they got pregnant. And even we could even follow them up and see the hospital records that they have after they've given birth, so that you get a more a wider picture of what happens. Record linkage, I think, is a really important aspect of thinking about national data, to really reflect the complexity of care and capture that in the data you need. So the diversity of data sources is really helpful to start thinking about right from the start, and then use what you need for the particular purpose of your policy question. As an epidemiologist, I really like to think about it from an epidemiological perspective. If people at a party, for instance, ask me what I do, then I say I answer two particular questions in my research. I always frame it like that, in a bit of a simplistic way. I say I try to understand why people with the same health problem get different treatments. And I also like to understand why people with the same health problem and who get the same treatment get different outcomes. So it's all about understanding the determinants of variation in process and outcome. And that is, I think, a very key element of my talk today. If you use national data sets, you really need to keep a clear structure of what you try to achieve. And I always recommend to think about it in an epidemiological context. Determinants of processes, determinants of outcomes, just like classic epidemiology is about determinants of particular disease occurrences. And this is in itself, methodologically and with respect to the approaches used, very, very similar, if not the same. And then there are two types of questions. Sometimes there are clear recommendations for practice. And I think then the questions then become, are we doing what we should be doing? And sometimes there are no recommendations. And then the question with respect to processes is what are we doing in the first place? And I'm always struck that in a lot of the work that we do, we work in a world where, our analysis are more likely to give answers to questions where there are no specific recommendations. So more answering questions that can be summarized the label "What are we doing?" than situations where we have recommendations for practice and where the questions turn into something like, "Are we doing what we should be doing?" And outcomes are, of course, always important as well. What is the outcome of what we are doing in the context of no recommendations? And if there are recommendations about what should happen, then the questions turn into something like, are we doing it well? But thinking about determinations of variation in processes and outcomes, I think, is really, really helpful. But there is, of course, a big problem. The type of data that I've spoken about is what you could call observational data. I think nowadays, observational data is labeled as real-world data, data that comes about just as life unfolds itself, data that follows care. And of course, observational data comes with all kinds of methodological differences. If you compare, for example, patients who did and did not get a particular treatment, you really need to be aware of confounding factors, because the determinants of outcomes, for instance, age of a patient or age of a particular group in the population, might have an impact on people's health, patients' health, but might also have an impact on the care of the interventions that patients get. So we need to think about confounding factors. And I think even more importantly, that might be slightly too simplistic. I think we need to start thinking a bit more in this context about causal pathways and use methodologies that are rapidly developing in causal mediation analysis, which I have to admit, as an epidemiologist, I find quite hard. Epidemiological approach, I can only warmly recommend it as an approach that keeps clarity, and that's all what we want. And then second, and I think it was highlighted yesterday as well, I think very often, if you think about a policy issue, you don't have an answerable question. And to be able to analyze large-scale national data sets or data sets that come from surveys, you need to turn a policy issue into an answerable question. And you define that by, I think we all have heard that several times, by thinking about something that people summarize with the PICO approach, population intervention comparison outcome. And this is more or less what it is about. Being very clear about the population. Is it everybody? Or is it, for instance, only cancer patients? Or is it only patients with a particular background? Is it only patients who get a particular treatment? What are the comparator groups? That is the intervention comparison element in the PICO acronym. What are confounders and mediators? Thinking a little bit more about confounding and causal pathways. And then what are the processes and outcomes? And I put that between quotation marks because that is in terms of the study design, our processes and outcomes are the outcomes of our research. What are the processes and outcomes that we want to include and study and consider? And that is important because if you can't really nail down, if you can't really be precise about any of those four components, then it's very difficult to make a start with analyzing these large-scale data sets, because it is really necessary to be absolutely clear about that, because it is important to have clarity about those four components, because you need to get information from your data sets to define and nail down all these particular issues. So let's look at an example again. A real-life example, a piece of work that we've just finished in England. There's lots of debate and there's lots of discussion about socioeconomic and ethnic inequalities in pregnancy outcomes. So that is the policy issue. And then we turned that into an answerable question. In women giving birth in National Health Service hospitals in England, which is supposed to give care at the point of need and to everybody in the same way, irrespective of background, are the risks of stillbirth and preterm birth associated with the women's socioeconomic and ethnic background. So in other words, I tried to define the population, that's women giving birth in NHS hospitals, and you could question whether that is precise enough. Then the comparator groups are defined according to their socioeconomic and their ethnic background. The confounders and mediators are, for instance, maternal age, how old the woman is, parity, did she have a baby before, obstetric history, some women have had a cesarean section, that might be important, pre-existing medical conditions, some women may have, for instance, diabetes, hypertension, whatever important condition, relevant conditions you may think of. And you need to think about the outcomes that you take into account here. And that could, for instance, be stillbirth, a baby born without signs of life, preterm birth, a baby born too early, or fetal growth restriction, a baby born small for his or her gestational age. And it is important to think about that, as I explained to you, because you need then to think about your study design in a way that you can expect that the data that you have can define all the necessary components to define the population, the comparator groups, the confounders and the mediators, and the outcome. So in this case, all women giving birth in the UK, there is a data set that is called the Maternity Information System that is routinely collected administrative data. It is partly also clinician reported. It's single episode, as I told you before. It's single data source. And also it is a cross-sectional study. We measure everything at the same time. We collect all data at the same time that we measure the comparators, confounders, outcomes. We don't need to follow up. So in other words, the question, the data, and the study design need to be brought together. And very often what we see is that a particular policy issue can't be immediately answered, but you can say, if we turn it slightly upside down, or we change the policy issue that we address slightly, then suddenly we can create an answerable question, and we have the data source. So basically, a policy issue is finding the answerable question and thinking about the data sources that you need is not a one-way process. Sometimes you need to go back and then change the answerable question slightly, and hoping that it still matches the policy issue to so that the data that you have or the data that you can collect is available. So far, only good news. And now I come to the particular example of my presentation, and that is an example from the National Maternity and Perinatal Audit. That's an audit that I lead methodologically. That's an audit of all women giving birth in the National Health Service in England, Scotland, and Wales. And first of all, one of the issues that we face, and I think that is not typical for England, it sounds all very easy. There is data, you can do a survey. But in our case, I think we found one of the most difficult issues is to get access to data. For instance, routinely collected data in many countries is within a particular context, within a hospital or within a regional health authority or within a Ministry of Health. And they have the data. And then for people like us, the academics or people supporting policy development, to get access of the data can be really, really hard. And simply to go beyond mentioning that as an example, I've given here a timeline for you of a particular request for data that we did to the English NHS. And you see that it started in September 2018. And we had all kinds of problems with for instance, we had to get the initial request right. That took ages. Then we had what we call data sharing agreement errors, a formal agreement between all kinds of parties that need to agree that everything is in place and that all conditions have been met. Then there were issues with the data itself. Then we didn't get the right data, and the hospital episode statistic, that administrative data of the NHS, was not always correct. Then we got it. Then there were data issues again. Then the body that had to be involved because things were wrong got involved. So basically, all that together led to an almost 2 years process to go from asking for the data, defining what you need, to receiving the data in a way that it is relevant for use. And that's what I want to put on the table. It looks quite straightforward, and it feels so relevant. We sometimes think that national data, at least in the context in which I work, don't play the role that it could play simply because of these delays, simply because of practicalities playing, of getting access to the data and being analyzing it. And I think that's a shame. And we're working very hard, for instance, with everybody and also the people on the regulatory side to reduce this delay between asking for data and receiving the data. And that's a process, I think, that will take many, many years. So that is the information governance and data access issue. Another issue that needs to be considered, and it can also be quite time consuming, is that you have to go through a process which I call data science. And I put it in quotation marks because data science can be quite complex and advanced, but in my case, it's quite simple. You have to come up with coding schemes. And with that, I mean, you have to find data items that can help you to define your population in your data set. You have to come up with data items that can help you to define and recognize the comparator groups. And you have to come up with data items that can allow you to identify patients that have particular outcomes, so that you can really analyze those data in an epidemiological context. And that's not always easy. And that is also sometimes a process that if you underestimate it, you can make mistakes. And for instance, we have occasionally done that. And then you have a national report that you have to withdraw because what you produce is, for instance, biased because you overlooked a particular issue and the population that you studied is not the population that people think you studied, or the comparator groups are not well defined. In our case, it had something to do with the cesarean section rate in pregnant women, for example. And I think you have to really do that in a way that you can be confident about the robustness of these coding schemes and the coding of these elements. You have to think about, let me take that away, the paper away. Sorry. You have to think about the validity. You have to of what you have. For instance, if you have an outcome, are differences in these outcomes really reflecting worse care or worse outcomes? Those kind of questions. You have to think about the statistical power. What is the chance of detecting a true difference? You have to think about how well can these key components be defined based on the specific data items that we have access to. And you have to think about the fairness of it. Confounding by clinical indication for people who have a bit of an epidemiological background is, of course, underlying everything. Some patients have more severe disease. But those are also the patients who are more likely to get particular treatments. And if you can't disentangle the severity of disease and the chance of getting a treatment well enough, then you can see that both understanding what the severity of this of treatment does in terms of determining outcome, or what receiving the treatment does in terms of determining outcome can be quite difficult. So the fairness, looking at the opportunities you have to really adjust for confounding issues is a key element. Data science before you start working. And we, for instance, try to do it in a way that if you go through this, that you also really make very explicit how you dealt with this process. And then we try to write it in a peer-reviewed paper. The next issue, the next challenge is that these large data sets, whatever their characteristics, whether they're routinely collected or whether they come from dedicated collection exercises, or whether they come from clinicians or from an administrative source, or whether they're lab data or not, and whether they're a single episode, or whether they are longitudinal, or whether they're linked or unlinked, all those things, these data sources are never perfect. And a big problem is missing data. That could be either patients not being included that should be there, case ascertainment, as we call that, that some patients are basically not ascertained in the data. But it can also be that for patients who are included in the data, or people who are included in the data, if you take a more public health perspective, that simply data items are missing. And then you need to think what to do. Only analyzing patients for whom you have people for whom you have complete data sets or not. And then you have to go to, maybe if you don't want to do that, you have to go to statistical issues. And very often we use now statistical imputation techniques to overcome missing data issues. but I have to admit we use them, but not always in a fully justified way. And I think there is lots of work to do. The risk adjustment, I don't have to elaborate on that a lot more because I've already told you about that. The risk adjustment, adjusting for case mix, adjusting for confounding is a key issue. And then the last thing in terms of statistical methods is not only the calculations that are important, you also have to think about how you display your results. And I think that is important because the play of chance and the impact of data quality is often underestimated. So we have to be aware, however you go to all these, however carefully you go to all these steps, that is a poor signal to noise ratio. Okay, let me give you an example. As I said to you before, the National Maternity and Perinatal Audit is an audit, and that is a quality assessment, quality assurance, quality improvement project, all combined of maternity services, maternity units in England, Scotland, and Wales, and we try to evaluate process and outcome of maternity care in order to identify good practice and areas for improvement. So it is particularly important to see it as a whole exercise, assessment, assurance, and improvement. And in England, there is an ongoing concern about that women from more deprived socioeconomic backgrounds and minority ethnic groups have poorer pregnancy outcomes. In other words, simplistic, women who are from poorer groups, poorer women, less affluent women, more deprived women have poorer outcomes than more affluent, richer women, and women from what we call here a minority ethnic background. And I use the word simply to capture that in a simple phrase, and it's not completely the right phrase, but for simplicity, women from a non-white ethnic background have poorer pregnancy outcomes than women from a white background. And we did a piece of work around that. And we looked at a data set that we got from the NHS. It's a single episode data set. Let's not talk too long about it. And we have data from women born between 2015 and 2017, a long time ago, also because of data delays. And we included about 1.5 women who gave birth to a singleton baby. So we excluded twin pregnancies. And in that analysis, we looked at stillbirths, for example, and preterm births. And we looked at it according to socioeconomic quintile and ethnic group. And if you look at the stillbirths graph on the right, you can see that if the socioeconomic quintile goes up, means that women are from more deprived areas, the stillbirth rates go up. And the pink segments are basically the excess rates in those groups. And if you look at the ethnic groups in the stillbirth graph, you see if women are from non-white South Asian, Black or mixed background, you see that stillbirth rates are higher, especially in the Black women. And if you look at preterm births, you see something similar, especially for socioeconomic quintile, women from more deprived backgrounds, in other words, poorer women have worse pregnancy outcomes, higher preterm birth rates, but the effect in ethnic group was not as high. And as an epidemiologist, we then tried to see how can we capture those differences as well. And we calculated something that we call population attributable fractions, and that is of course slightly abstract, but that comes down to the proportion of poor outcomes, the proportion of stillbirth or the proportion of preterm birth that would not have occurred if all women had the same risk as the women in the least deprived socioeconomic group, or women at the same risk as women who have a white ethnic background. So that means that is something that captured what could be thought about as maybe preventable by addressing these particular risk factors, socioeconomic deprivation and ethnicity. So we reported in our paper, in our policy brief, or in an attempt to write a policy brief, that 24% of stillbirths were attributable to socioeconomic deprivation, so 1 in 4, and 19% of stillbirths were involved in the variation across ethnic groups. And the same we did for preterm births, 12%, could be attributable to socioeconomic deprivation and 1% to ethnicity. And that's a measure that we try to put in place to demonstrate the policy relevance of spending time on trying to address these deprivations at a particular rate. And then we turned it into policy briefs. And we didn't do it very well because we wrote policy briefs that were too long, but we wrote them for different audiences. So we have a whole report about them. We wrote something specifically for the wider public and for women and families themselves, a lay summary. We also were explicit in wanting to publish this in a peer-reviewed journal to demonstrate the robustness of our approach. And we tried to make sure that there was some attention in the national newspaper. And as an epidemiologist, I was particularly proud to see a population attributable fraction. You see here the 24% of stillbirths that could be prevented if all women had the same stillbirth risk as those in the least deprived, the most affluent quintile, quoted in one of the national papers in the UK last year. So that's an example of how we use national data sets to respond to a particular policy issue and then produce outputs for different audiences. And now I think it's up to you. And I think I would like to hear from you, and maybe we can do that through the chat. And that would be really helpful to get your input. Let me see. I would like to ask you to write in the chat to identify some possible topics for policy briefs for which analysis of national data and surveys can provide relevant evidence. So especially topics in your own practice, in your own context, in your own country, where you feel that's an area for which these national data sets and surveys can be used. If you can put them in the chat, I'm going to stop sharing at the moment, because then I can see what the chat is, because I always lose that a bit. And then I would like to see if people put something in the chat, to what extent we could then talk about what that would mean, what kind of questions that would involve, what data is available, and we could maybe use one or two examples to go in a little bit more detail, and then we bring it to an end at around 12 o'clock. And my talk, I realized that has been much too long, because we are only 10 minutes left for the workshop. So I think it would be very good if we could start thinking about the first question: identify possible topics for policy briefs for which analysis of national data and surveys can provide relevant evidence. And then I think there must be one or two examples that we then can talk a little bit more in more detail about, to see what it means and what the challenges would be to make that happen. I think I've got here some Munyahawa. Are women facing higher catastrophic, worse health than men? I think. Can I ask you to elaborate on that a little bit, and then we can see to what extent how that would work if you think about national data sets and what data you would require for that.
Hello, thank you very much for the presentation. So in this question, we're trying to understand if there is some sort of differences between, like, in gender-based. If women, for instance, are, let's say, the main breadwinner of a household, and there are also, we are talking about a certain context with a specific socioeconomic situation. So if women are the main breadwinner, and do they in certain cases face more financial hardship to access healthcare services than if the situation was if we have a household that where the breadwinner is a male? So in this case, we're trying to see if there are inequities related to gender.
Yeah. No, yeah, and I think immediately, in my epidemiological head, I'm thinking, and I hope you've done that as well, think about what is the population in this design? What is even the unit of interest? Is that households, or is that women, or is that the entire population? What is the actual comparison? I think something to do with being a breadwinner, yes or no, but how can you capture that? Where can you get the data from? So I'm in my head, because I'm doing this work now for 30 years, I immediately go into the epidemiologist mode, framing an answerable question and translating immediately these components into data needs and explore to what extent these data needs can be met by looking at the data that are available. So my question to you would be, would there be existing data that would cover that particular topic, that you can define, for instance, households with a male household with a female breadwinner,
Yes,
that can cover access to healthcare, socioeconomic differences? Because that is, of course, the next question. You need to define your study design, you answer the question, and then move to the data.
Yes, we have in Palestine, the Palestinian Central Bureau of Statistics. They conduct a census and a household survey. It's called the PEX survey on the consumption, and it's a household survey. It's conducted every several years. And it's, I think we would have data like from 1996 until 2017, and the new one is being updated. So in terms of the data, we will have like some data. The more problematic part could be in terms of like the issue of the accessibility to healthcare services. We would have less data on that. So usually, like if we're talking about data taken from the Palestinian Central Bureau of Statistics and Surveys, so this is quite routine and we will have it available. We will not have problem accessing it. But the issue of, again, the access is maybe we would need to like undergo some sort of a different data collection mode in order to check in that area.
Yeah, no, that is really, really interesting. Is there one more example that we could look at? Because I realize that it's 12 o'clock in Cairo now, and I'm supposed to hand over.
There is another, suggestion from Dr. Sabria. She said that assess the acceptance of population to COVID-19 vaccine.
Yeah, that's a very, very good one. So Sabria,
Yes,
can I ask you to tell a little bit more about what type of question and policy issue and policy brief you're trying to address?
Hello, everyone. Actually, here we want to assess the acceptance of population to COVID-19 vaccine. So the population will be, for example, if we take Oman as one of the examples, so we'll take the Omani and non-Omani, both of them, and because it is a survey, so we have to choose which one it will be like a survey. I'm sorry for that.
No, we like that. Children's voices are always welcome.
So, and then we have to know if we will do it like by phone survey, or it's like a paper distribute to the community, or we will pick the population from the health center. And then after that, we have to, if, for example, we choose the phone survey, we have to look for specific criteria for the participant who will be from our group. So this participant will be like, for example, above 18 years, because we cannot take like less than 18 years for the children, right? And I'm in the right way?
Yeah.
Okay. And then also,
carry on.
And then also we have to look for the people have to understand our language. Like, for example, here we would choose Arabic, English. And for example, like we have some migrant because we choose non-Omani. So we will choose which is the most population, another nationality here, for example, like Urdu or this language. And then we will we will assess their knowledge regarding the vaccine, and then regarding the disease first. If they know the disease, so then we will ask them regarding the vaccine and attitude and the practice toward this vaccine. And then we will correlate between their acceptance, between their knowledge and nationality, and knowledge and nationality, and also the source of information they get about the vaccine. Because we want also to stop the rumor. If we know the source, so we can stop the rumor.
Yeah.
Yeah.
I think what you describe is basically in great detail exactly I think what you should be doing. You talk about who you want to cover, yeah, how you want to collect the data, what your comparison groups are to understand, for instance, what are the determinants of coverage. You also try all kinds of methods to make sure that you don't lose patients because of particular issues like language problems, so that you get selective inclusion, which would create a bias in your results. So in other words, I think without making it extremely explicit, you use, and I'm really keen on lifting that out, you use epidemiological methods to get answers which are as accurate and as precise as possible. Also in a way that what you do is just responding to the particular question that you get. And then in terms of the practicalities, I think you already highlight that, and that's what I experience as well, that they should not be underestimated, isn't it? Getting a survey out, getting high response rates is hard, but also if you have information about who gets vaccine or not, getting access to that data could be another approach. Routinely collected data. To get access to the data might also not be very easy. Well, thank you very much. So we go to one more. So we go to one more, and then call it a day as far as I'm concerned. And then I simply pick one. This is not based on that this one is better than the others, but simply this one catches my eye. Prevalence and determinants of dental caries, rural and urban areas in early school age in developing country. That is Abu Talib. Hala.
Hello, this is me, Hala. I'm
Sorry
a London
about...
school graduate, so I'm very happy. You remind me of my school days.
All right. I hope happy memories.
I'm an epidemiologist, so I hope I don't ruin all my. I didn't forget all my basics. So the reason why I chose this problem is that we need in countries like Egypt, for example, and developing countries, a preventable disease like dental caries is not taken. There's a lot of problems that we face in the later years of life in children. So it's very important to have a preventative approach. So a lot of policies have failed in addressing this problem, and the country is facing a lot of economic and health consequences as a result. So I was thinking that it would be useful to understand what's the prevalence, the magnitude of the problem, what are the differences, the underlying determinants and causes that we could really prioritize and address in our policy. So, and I focused on early school age, like screening, because there could be like actions like screening that the government can recommend, like screening of school at school entry. That's what I've been thinking, that this data could be done at school entry age as an entrance to schooling. At the same time, rural urban factors are very important because of the nature of eating habits, because it's not really related to poverty rather than to eating habits and unhealthy habits. And sometimes dental caries is even less prevalent in rural areas than we expect. So it's very interesting to understand the differences because there could be different policy options. And it's very useful also to understand the hygienic factors and different factors that we can act and we can recommend and take policy and programmatic actions accordingly. So that's what I was thinking of. I was thinking while I was formulating this problem of who is the most prevalent vulnerable groups, where can we find them and how can we find the best data that can serve, and that's it.
Yeah.
Over to you.
No, I think that is really, really interesting, and that is, I think, a question relevant for, I think, all countries. Yeah, all countries have the kind of the emphasis on I think you will call it dental health has changed a lot in many countries because of adding fluoride to the drinking water, but still there are issues to do with what I would call inequalities. It's for instance, in England, it's very much linked to whether children come from poor or more affluent families, for example, and knowing that also helps. And what you highlight is exactly the thinking that you already have started to think about your population. Yeah, that is kids at school entrance. Yeah, you want to find out particular determinants. Yeah, and that could be, for example, rural or urban, but it could also a little bit more about the backgrounds of the families. You think about it as a cross-sectional study, you know, that is all data is collected at one point in time. You think about how the national data or how the survey is being carried out. How can you ensure that you have reasonable coverage so that you don't get selective inclusion that might distort your findings? So in other words, I think you do exactly what an epidemiologist of the London School of Hygiene is supposed to be doing. And I think that is a fantastic approach. On the other hand, I think it's also highlighting the kind of thoughts that Christopher Colvin gave. This quantitative data is one thing, but then the so what issue kicks in. What can we do, for instance, to reduce it? And then the epidemiological work can show what are the determinants. Is it urban, rural? Is it maybe related to the affluence, whether families are poorer or richer? But that doesn't necessarily then lead to the steps to do the preventive, because people, whether you want it or not, will remain poor. People will stay living either urban and rural. The kind of interventions and understanding about why it happens, how it can be addressed, how families think about dental health as an important issue. Qualitative work around that, I think, is of course an important component as well. So you can see how these different components of the course that we have yesterday and today brilliantly support each other. So thank you very much.
I see that the qualitative research will be required to complement the data to have more in-depth understanding about any behaviors and what are the underlying causes of those behaviors. Yes, thank you.
So thank you very much. Thank you very much, everybody, for listening to me. And I think it's time for me now to hand over to Menash and I think also to Arash Rashidian. It was a pleasure to speak to you.
I would like to say hello again to all colleagues with us. Good morning, good afternoon. And also knowing that it's difficult to participate in online workshops, so we try to make it interactive as much as possible. So with the questions and answers so far, but still I know you are for you it's not an easy position to be in, and hope it remains effective and helpful to all colleagues. Okay, my focus is on policy dialogue in this session, and we'll quickly go through some of the objectives about the participants, the organization, and look at the outcomes, potential outcomes of a policy dialogue. So that's the focus. So I'm not going to discuss this further. We referred to it yesterday, just saying that when we talk about policy dialogue, is part of the knowledge translation cycle, and it will be linked to all other programs. So it can be used with all other programs in a sort of if very relevant and when it is important for that process. And again, this is part of the regional action plan. I'm not referring to that. I'm just keeping this as a reference in the slide set. Okay, so first, let's get to the same understanding of policy dialogue. Like many other terminologies, it's been used in so many different ways. So what we mean here as policy dialogue is a sort of, I try to give a definition that summarizes it. So it's a deliberative issue-focused dialogue between policymakers and other key stakeholders that have interest in the topic. And the last bit is also important. So it has three elements: being deliberative, being issue-focused. So it's a focus on certain policies. So it's not a general discussion about problems. It has a plan. It's planned, programmed, and followed based on that. It involves key stakeholders. And it's done through usually a meeting. So it's always, I mean, almost always where what we are talking about is about certain types of meetings. So these meetings are better and often organized in roundtable approaches rather than a meeting that someone is on the table, everybody is sort of in front. So anyways, it's bring people together. So this is important because the word policy dialogue is used in so many different ways. For example, even within WHO, when we talk of policy dialogue in general, we are talking about any engagement, important engagement, high-level engagement with policymakers about health policies. And we call that policy dialogue, which is correct. What we are talking here in this session, and when we are talking of the policy cycle, when we talk of policy dialogue, it's not a general term for engagement. It's actually a tool, a technical sort of approach to a policy dialogue. And that's important to bear in mind. The other important issue for a policy dialogue to sort of note is that it can be actually initiated from different angles. So a policy dialogue could be a program requested or a tool, I mean, an approach engagement requested by a policymaker. So they have a question in mind, they have a policy in mind, they want to attract attention to it. They want to, for example, attract financial support to it. They want to bring other people. Sometimes they want to showcase the progress, and they may use the policy dialogue. But on the other hand, the policy dialogue could be initiated by people other than the policy maker responsible for the policy. It could be done, for example, by those who support a policy, and they want to sort of enhance that support or identify options for enhancing the policy, or those who disagree with the policy. So they may call it so that they show the challenges or demonstrate the challenges and perhaps hopefully resulting in their desired outcome, which might be changing certain policy options. What it should involve always are things like discussing of the evidence coming from research, from data, and we are talking about different sources of evidence since yesterday. Should involve discussion of policy options, so it should be focused on those programs, their disadvantages and advantages, implementation issues, and also what could be the sort of the important evaluation endpoints, something that we discussed later today in the sessions. And most importantly, it can occur at any stage of policy development or implementation. So let's go as a reminder. So in terms of the 4 stages of policymaking, and Ahmed gave that reminder this morning as well, in terms of what we had discussed in October. So policy formation, agenda setting, agreeing problem formation, my apologies. So agreeing what is the main problem, developing the policy, implementing it, and evaluating it. So how can policy dialogue be helpful at different stages? So obviously the purpose will be different at different stages of the cycle. So policy formation, agenda setting, policy dialogue will help to identify the problem, to make it more clear. We hear that very often, but it's something that should be told again and again. Very often the problem with the policies is that we do not spend enough time to define the problem very clearly. So we end up with the policy, we start with the policy that people have different understanding of the problem. They look at it in different ways, or they have not defined it really well. And then in the middle of development and implementation, disagreements start to show themselves. So because of not enough time spent on the problem formation. So if you do policy dialogue at that stage, or at the level of policy formulation, it will help you to focus on the problem, define the problem better. It will help you to identify policy options of interest. Because I mean, we do the sort of, I mean, look at so many different sources, but policy dialogue is an option that can help. If it's happening at the level of, at the time of policy implementation, it could be used sort of to support, advocate for implementation tools that they require. But it can also be during the process realizing there are problems or certain partners or stakeholders are not communicating or engaging well with the policy, so that policy dialogue can come in to try to advocate for that support. And at the level of policy evaluation would be a forum to evaluate, to look at the policy, and again, to maybe result in changing the policy itself as a result of that evaluation. Okay, so I stop here for a second and would like to see, I mean, first of all, I mean, if we can use that raising hand, so I want to use raising of hand as a sign of numbers. So how many of you have been involved or conducted a policy dialogue as defined in here? I mean, a deliberative meeting that has clear objective, focus on a certain policy and brings different stakeholders to discuss the policy. Can you please just raise your hand in the Zoom so that we can count? So we have 3 so far, 4. Okay, not many. So any one of you willing to share the experience? So if you wish, one person can open the camera and also start discussing that, please.
Yes, Arash.
Yes, please go ahead.
Yeah, thank you very much. Maybe I can share our experience in Palestine with our stakeholders in road safety area. When we're working on the road safety, injury prevention and safety promotion, we found several players and stakeholders working on several significant part of work, but they are not orchestrated their work in one effective way. So we opened the dialogue with all stakeholders. The first thing we did, we make all of them on one table. So we were able to bring all of them on one table. We opened the discussion not on vertical way like the previous period. We start systems thinking rather than vertical thinking, and from that point we elaborate on our roles and every stakeholder role and responsibility. Then we came with several concrete recommendations to make the road safety interventions more valid, more effective in Palestine. Really, it takes several years of discussions, but I'm talking about the idea of policy dialogue.
Many thanks. Yeah, absolutely. I mean, it could be part of a longer program, but then we are talking about the event that is called the policy dialogue. Even that event might require a lot of time to prepare for. So Mohammed, that was a very good example. Many thanks for sharing. Okay, so if I want to continue the discussion, so let's go to looking at the policy dialogue issue. I mean, so when we are thinking of the different steps of in preparation for a policy dialogue, the first thing is that what are the objectives of doing that? What are the expected outcomes for the policy dialogue? What we want out of it in the end? Are we, for example, seeking to have a consensus in the end, agreement on policies? So if that's the case, I mean, you may need to have certain consideration, but it may not be also an achievable objective always. This often is not the best objective for a policy dialogue, because that's the context of the sort of policy dialogue is not that amenable to getting to an agreement of all partners in the same room at the same time. So it may require further action. But being very clear on the objective is really important, especially if you are in charge of organizing it and going ahead with that agenda. The other thing to bear in mind at this issue is that the objectives may be a bit different. For example, you might be tasked to plan for a policy dialogue, and you assume you know what is the main objective of the policymaker who is asking you to do that. But then the intent of the policymaker may not be exactly as you have assumed. So it's really important to spend enough time with the policymaker to understand exactly what they want for it. Sometimes policymakers, for example, they are in a difficult policy making situation, and they want to use a meeting or a gathering to sort of reduce the tension, perhaps. So then maybe policy dialogue, as you define it here, may not be the best option. So it would be really important to spend time to be very clear on what are the objectives there. The second important element, and we heard that from Mohammed in his discussion, I mean, he referred not the detail, but he referred to that, identifying key stakeholders, the different groups that should be involved in that situation. So it's policymakers, usually so let's say, in health policy, we are often thinking of Ministry of Health as policymakers, but you will be surprised that even within Ministry of Health, there are policies that not all relevant stakeholders within Ministry of Health are aware of its development, etc. So it's really important to start thinking of within the context of different sectors within Ministry of Health. Different sector may not be the right word. Different sections within the Ministry of Health, how they should be involved, and then going beyond that to all different stakeholders from outside. So I refer to that a bit later. The third step is that planning for the meeting. So I mean, it's a meeting that should be very well planned in different areas, different aspects of it. The sort of obviously the date of the meeting, give it enough time. The location is key, very important. The chair, who is going to chair it or facilitate it, different groups use different terminology. I deliberately keep those terms because sometimes the chair may not be the right title for a certain policy dialogue session. Sometimes facilitator may not be the right word, although the function that we ask doesn't matter which title we use for it, because the functions are very clear that should be done in a certain way. I come back to that later on, but I want to emphasize right now, even if you call it the chair, is not in the general understanding of a chair who is the head of that agenda and makes the final decision. The chair here would be his or her main role would be to ensure the views are well discussed, well sort of become clear, and then the chair can help the group to get to the objectives. That's the role, not to summarize and make the decision by the chair, which is, I mean, sometimes it's not the correct use of the ability given to a chair position. So in a way, I mean, if I want to sort of make light of the situation, I would say, I mean, planning for a policy dialogue should be considered similar to planning for a marriage ceremony. You really need to think about the details. The policy dialogues may fail just because you have not done good planning for the room setting, for the sort of the interaction situation, the details of it. That's absolutely important. Is important, and that's the analogy I made with the marriage ceremony actually helps, because as in marriage ceremony, if you plan even for months and then still there might be a problem last minute, policy dialogue could also be like this. Last minute changes in who is wanting to come or want not to come, or sort of the way they interact with the event. And then engaging with the stakeholders well in advance. The minimum engagement is that the documents they need to know, sharing with them the objectives, whether they want to add to the objectives of the policy dialogue, would that be permissible or not? Would that be a sort of a diversion? Or knowing all those things, even if they are not in agreement with your plan, is much better than getting to know them in the middle of the policy dialogue session, the meeting itself. So these are, I mean, the four sort of key elements, but each one of them actually requires attention to the details on how to take it forward. So some groups, as I mentioned, so policymakers responsible for the policy, other relevant policymakers, other sections within the Ministry of Health, other sectors of the government, academia. It's really important to have the engagement of academia, especially academia with the interest and those who have been involved in developing evidence on different elements of the policy problem. Sometimes also when we talk of, now we are having our Net2P members with us, several of Net2P members institutions are academic institutions. So you might be actually even hosting a policy dialogue. So in a way, you may also be thinking of what are the other academic groups that should be involved. Health professionals, media. So how to involve media is a sort of, should be as part of your bigger objective for the session. Because of, the way, I go to that issue later. So the level of details you want to discuss after, based on the sort of, sort of the meeting itself, and also the level of sensitivity of the topic may or may not help you to decide whether to have media in or not, and whether if media comes in would be with certain conditions or they are allowed to report on it as they wish. The civil society, patient groups, etc. So all those issues. So I now bring an examples for us to discuss, and I would like to see your reaction to that. And maybe this is not an area for all of you. The sort of improving civil registration and vital statistics in countries. So I don't know whether the terminology is familiar for all of you or not. Civil registration and vital statistics is about, registration of the main civil events in our lives, birth, death, some marriage, divorce. So these are the minimum, but in many countries, these officers, they do some other important civil registration issues. For us in health, the two elements that are really important are death and birth. So recording them and also reporting on them accurately. And for death, the cause of death, which is absolutely important for the WHO. See the table I put here? This is just about the sort of coverage registration in countries of the region. So there are a lot of limitations in several countries of the region in terms of registration of deaths, which is one of the important things. So this is why, this is a major program for WHO, at least in the last 7 years. And there have been important progress, and some of these figures have improved in the last few years. And getting to these figures I'm reporting here. The other issue is that they do not also show, the figures I'm putting here do not show the sort of the quality of the registration of cause of death, because that's in many countries, even when they have high registration, primary registration rate, the cause of death may not be recorded properly. Okay, so that's what the context I was giving to you. So you are tasked to sort of to conduct a policy dialogue to advance, to advocate for change in the status. By that, I mean to improve the situation for civil registration and vital statistics. Who are your key stakeholders? So, if you kindly put the name of stakeholders that you think, be specific, don't say media or media actually could be, but if you can be more specific, but think of certain groups. If you say policymakers, which policymakers, which groups? So if you kindly put, yes, of entities and organizations that are responsible. So in the that's true, because in one country or the other, it might change from one to the other. But if you mention who is responsible in your own country, Ministry of Interior, because of the responsibilities that they have, absolutely. Who else? So I saw a long list from Russia. So Ministry of Interior, hospitals themselves. So then if you say that, then you need to think of who many or academia relevant position responsible. So that's helpful. So in terms of Ali putting civil registration and NADRA in Pakistan as key stakeholders. Actually, right now there is a meeting in Pakistan about civil improving reporting on cause of death, which is happening. So again, from Pakistan, KM, you're seeing the same thing. Abdul Ghani mentioning national statistic information in Afghanistan, absolutely. Minister of Interior mentioned again, legal medicine organization, absolutely. Mashiane, that's really relevant because of the role they have in sort of certification of maybe a large group of deaths depending on the rules in the country. Reza mentioned responsible hospital information systems. Who else? So I would add, so Ministry of Justice could be in certain countries. For example, if you have a high proportion of hospitals are run by the military service might become part of your stakeholders. The civil legislation groups in countries from one country to the other country, the engagement might be different. So you can see, for a very specific topic, when you want to be successful, you really need to think of a large group of stakeholders to push it forward. And again, this is something that, for example, that WHO does a sort of policy-oriented dialogue. We call it engagement with countries, and it has happened in all countries of the region. And within that, a lot of preparation with the country responsible people, I mean, the WHO team in regional office, country office together, they identify these key stakeholders, they bring them together. So that's the way we think about it. I mean, and as you can see, so I mean, it may take time, not be made. Myself as the person responsible for policy dialogue planning may not be aware of it. So they actually, I need to consult to identify who are the key stakeholders. And then you think of the practicality, like the feedback I gave earlier. So if your list becomes too long, then you need to think of, well, do I need to invite all of them? Are they key stakeholders? Because there could be much more stakeholders than the key ones. You don't want to miss anyone that is important, but you do not want to also to make it too big so that the dialogue itself might not become an effective dialogue the way you intend for your plan. Okay, so now I have another question from you, and I'd like to really, so I just opened the chat box and also further coroner office. I mean, that would be the legal medicine, similar medical syndicate. Yes, okay, excellent suggestion for that one. So my next question is now, I mentioned about the role of chair and facilitator. So I'm asking you kindly to list the characteristic of a suitable chair for the dialogue itself. So who is the best? Well, there is a question, I mean, Mehnaz, I mean, you're asking about the maximum numbers. So, I mean, these meetings are usually larger than what we have, a sort of a normal, because, you know, there are rules for sort of meeting that you want to, so decision-making meetings. In decision-making meetings, I mean, there is, believe it or not, there are theories about group interaction, theories of group interaction in sociology. There are PhD theses on it. There is a lot of very useful studies. According to those studies, I mean, when you are making meeting for a decision-making, so below 6 usually is too small as for a meeting interaction, what you call it, and so above 12 is too many. So I mean, usually between 9 to 12 is the recommendation for membership, or maybe 7 to 12. But when it comes to policy dialogue, the number is often much bigger. So I mean, up to a few tens would be fine. I mean, 40, 50 would be fine for such a purpose. Okay, so going for the chair question, so sorry, I'm coming back to this question I asked. So, saying that should be someone maybe in charge of the policy. So, Shiraz, I mean, that's a good suggestion. I mean, we can think about those suggestions later on. So, so from history of policy angle, so should someone, so Ali mentioned someone being inclusive, being able to run and do the timekeeping, allowing this. So in a way, the neutrality has been emphasized here, again from Hala the same. But then Hala has added that the person should be well respected, experienced, good listener. These are, I mean, the characteristics for every good chair that we need to think about. And for such a meeting, that's absolutely important. Rasha mentioned being knowledgeable to the topic, knowing those who are being invited. So I mean, in a way, so being recognized in the topic as well. So then this issue is similar to what you mentioned about, I mean, someone from Ministry of Health. I mean, what you need to bear in mind is that if the policy is a policy that there are important stakeholders that oppose the position of Ministry of Health. So then for a policy dialogue, probably having someone from Ministry of Health may not be the best option, because then from the start, people will start guard against the chair, and then you will not have the policy dialogue. So you need to get it as close as possible to neutrality. The same goes if the person is well known to the others. So then it's probably a person that is well involved. Is that involvement is that the person has a position that is opposed by some of the key members, then perhaps that person is not the best chair for that situation. Who else being added here? Someone who has good knowledge. We mentioned that authority, yes. I mean, being a sort of a level of seniority is really important. If you are inviting very senior people, the chair should be to that status. I mean, someone who's good and represent reputation, research policy community. So Tana, that's a good point. From Reza, good communication, convening power. So good communication skill, etc. So as you can see, and then if you put these criteria and within, so I haven't populated the slide. I'm realizing if I cannot type right on it, if I need to type, I need to stop sharing and resharing again, so it will take time. So I'm not going to do that. So in a way, in the we will share with you a revised slide. So I will add your ideas and also the ideas that are generally discussed on what the characteristics of the suitable chair. The reason this discussion was important, just to share with you, it's a very, very important. So I mean, in a way, it's a win or lose scenario, depending who is the chair or facilitator of the session. The person should really be knowing the task, being able to do it and do it properly for the policy dialogue to achieve its objective. So it's a major part of it. Okay, so let's go to the back to the discussion. So running a policy dialogue, this is really important, and I really want also to have your reflection. So I mean, please, maybe one or two of you would raise hand and also share opinion on that. So, I mean, think about the rules of engagement in the policy dialogue. I mean, as simple as, the things we say in this sort of workshop, please, make sure your microphone remains muted. Don't jump into discussion because, it's a sort of remote connection approach, but then raise your hand if you want to engage, etc. So, those certain rules. There are certain rules being discussed. I've seen documents, including from WHO teams. Different, for example, WHO Euro team a few years ago, they published something on it, and they suggested perhaps the Chatham House rules could be followed. So what is the Chatham House? Chatham House is a sort of an office, or it's actually that there is a building as well for it in the UK, and they have certain policies, principles for discussion, and the rules they've established since the start has become a terminology for itself. So is that, you attend the meeting, they invite people to this meeting, or any situation. If, let's say, your policy dialogue follows the same ruling, participants are free to use the information received, whatever they hear from each other. But when they refer to it, they should not identify who said what, and they should not say, what was the affiliation of the speaker either. So referring to it, but not saying someone from Ministry of Health. And then they should not also sort of reveal afterward who was participating. So in a way, it's an environment for free discussion for any sensitive issues, so that people can say their minds very easily. That's absolutely really important. But then it might conflict with another principle that we advocate for policy dialogue, which is transparency. So for transparency, one important key is that you really need to report at least who was present in the meeting. So that's a major important element of transparency of the findings. So that from my point of view, that's the minimum you should stick. So if you say Chatham House rules, and then you say transparency, you really need to define what are the limits of each one of those. And so I'd like to hear your reflection on those. The other approach would be a sort of Robin Rounds approach. If colleagues have done consensus building, it's very useful for that, but it's also a good approach for making sure everybody's engaged. But then if the meeting involves so many people, then it may not be practical. So you really need to think of whether it works for your context or not. So in a way, you sort of, for example, let's say your policy dialogue is for identifying policy options, and you do not want to miss any policy option. So you go a Robin round. So you start, for example, from your left or your right, and then each person, one after each other, you'll be saying that you can add one suggestion only, and that's it. And so if you have even 3 suggestions, don't mention it. So it goes around. Sort of the reason you do not open for more than one suggestion is that you want to allow other people to engage into the discussion. But then you go next round, and the next round you would ask, is there anyone who wants to add? And then you continue like this, then until you receive all the key suggestions coming forward. So it might be good, but I mean, again, if the team is big or if there are heated discussion, may not work. You need to think of in advance time allocated to each person, or sort of how much time each person would have, and then the chair should be able to control it. Would you be focusing on free discussion? Is that, I mean, by that I mean people will be allowed to say things, and then you say as a rule, please do not directly respond to people, express your views, or allowing interaction so that there may be more clarities, but then there is a risk of heated discussion coming. And then another rule would be that do you want consensus or not? Think about it in advance. So I mean, if it's okay to reach consensus, even if you have not planned for it. But if you plan for reaching consensus, the design of your meeting should follow a certain element so that it would be a possibility. So what I'd like to hear from you is that, so I mean, the issue of transparency of the discussion, the issue of, I mean, sensitivity of the topic, being able to discuss without revealing, I mean, to the outside, that also would indicate whether you want to invite media or not, or inviting media with certain limitations that you need to define. So anyone want to reflect on these elements, please? So I don't see any raised hands, but if someone has any idea. Maybe the other three colleagues who have done policy dialogue, other than Mohammed. So Nassim, please go ahead. You need to unmute your microphone. I cannot hear you if you are talking.
Now, can you hear me? Hi, and thank you. Sorry, I'm in the office, so it's a bit, but thank you for this. And, I got a bit disrupted in the middle, but thinking of the Chatham House rules and the digitalization that we're moving into, I think you already mentioned something about it, but how do we respect that and keep that with a lot of meetings being recorded, with the new online way of conducting some of these meetings? And I mean, I think that's a very important part of the discussion, because it's also a question of creating a secure space, but also an innovative space where new thoughts and new ways of thinking should be possible. So that's just one. I think it's a key aspect to be able to keep the Chatham House rule. And even when it comes to time allocated, all of these questions come to a new point when we talk about the digital ways of interacting. So just wanted to raise that and maybe see also what other colleagues think and what experiences there are.
Many thanks indeed, Nassim. That's very helpful. In a way, these are the issues. I mean, there aren't any hard rules for this. So it's really important to think about them. And if you mention something, you really need to be, I mean, sort of true to it. If you say the data will not be shared, then you really need to plan for it when it's done. That when you are in a position to do that. But then, obviously, this is something, I mean, I don't personally recommend. I mean, policy dialogue, one benefit of it is that actually it makes transparent the positions and also options. So that's the benefit. When you lose that benefit, so you need to really be in a position that you get something big out of it if you want to reduce transparency. Okay, so Mohammed, do you want to add something? Maybe very quick note, 1 minute. Please.
Yes, very quick. Sometimes there is some people in high official position, like a minister or deputy minister. So in that time, we have to respect some protocol that already used in the country. For example, if you invited all the stakeholders and the core stakeholder, for example, is Ministry of Health, so you have to make them to open the meeting, then give the floor for other based on their priority and power. Sometimes it's a sensitive, but we have to do that protocol, because at the end of the meeting, if you started the meeting without giving them the floor at the beginning, they will ask, we are the core stakeholder, and we have the data, we have the law, the power. All interventions are, for example, from our side. So while we are talking, we'll be talking at the end. So that's just the one.
I think that's really important, and that's a reality that you are mentioning. In a way, I mean, this is also fine. I mean, opening the session, especially if they are policy owner, they are asking for it. They would say, I mean, this is our interest, what they are doing, what's their intention. They can actually specify the objectives. But what you really need to bear in mind, the policy dialogue will work only if there isn't much of seniority when you are doing the discussion. So if someone becomes dominant voice there, as you see, for example, so the policy dialogue is not a normal meeting that the Minister of Health would arrange, invite people. So saying that, I mean, a deputy minister or a minister is in the meeting, and then they would decide saying that, oh, stopping this discussion here, or you do not need to continue the discussion, because that's a decision-making sort of approach, whether that's a correct way of doing it or not. But policy dialogue opening is fine. I mean, giving those positions, I mean, even they might have closing remarks, but the dialogue itself, it should allow other people to raise their views freely, and they should not be intimidated, they should not be limited. Otherwise, don't call it policy dialogue. I mean, if that becomes a challenge, you can say that we have a consultative meeting, which is fine, and it's really helpful. If you call it policy dialogue, I mean, that engagement should be following those rules that people can engage really well. So that's really important. The other important element that follows the same issue is that the issue of conflict of interest. I mean, there are, let's say, I mean, I'll give you one example. Let's say, I mean, you are discussing policies on reducing fatty food consumption. And so who are your key stakeholders? Some of your key stakeholders are actually those who produce these products. And then they are against any policy that might say, well, change it like this, or change the production line in that way, etc., etc. Do you want to engage them in the meeting or not, in the policy dialogue or not? You don't engage them, you lose certain elements. But if you engage them, they may not behave the way you expect. They may try to divert the discussion. They may bring certain elements into that. So you really need to think hard about it. The other thing is that prepare yourself to inform the chair facilitator about any important conflict. So at least, I mean, you need to know who might come with a baggage of interest in their mind that is not in line with the sort of the best benefits of the public or the best benefits of the policy in question itself. So then you need to prepare yourself how to manage that, whether chair would be in a position or the facilitator would be in a position to do that. And then to ensuring how they do not affect the deliberations during the meeting. So as the same goes, I mean, let's say you are having a policy dialogue involving a major policy of the Ministry of Health. And then, so there are people who do not like the policy, or they have maybe valid reasons or certain points that they think the policy should be adjusted. How would you manage if a sort of senior policymaker suddenly seeing that, for example, people are negatively reacting to their policy if they want to sort of stop that discussion going in that direction? How will you manage that? So the role of the chair facilitator is absolutely the key. And it's not an easy, I'm not making it, I'm not trivializing it. I've been in that position of sort of chairing such sessions. And I know how it can become very difficult to manage if those issues come forward. But plan as much as you can. It's like, again, think of the marriage ceremony. You have a remote cousin that you have to invite, but you are worried that remote cousin might say something that other people might be offended. Then you need to think about it, how we can manage that if that things happens, and that how it might go forward. So in a way, those conflict of interest is really important. And sometimes you are not aware of conflict of interest, but then perhaps, I mean, you need to prepare as much as possible. In terms of documentation of it, so careful note taking is key. Plan for it. I mean, I'm saying plan for it because I've seen certain meetings that, I mean, sort of, I mean, this discussion saying that, okay, I have a colleague that is going to take note, but then the same colleague has 5 other things to do. Plan for it very well. I mean, usually more than one person is needed. That person should not have anything else to do within the period of the meeting, just to take note. Even if you are recording the policy dialogue, taking notes is absolutely important, because it gives more information than the sort of the recording itself. Inform the participant in advance if the meeting is being recorded. Are you going to have a detailed meeting report, point by point, who said what? Or are you going to have a summary report coming? So again, plan for that in advance, be transparent, say that at the start to the people who are in the meeting, that this is the way that the meeting report should go. And sort of, again, when we go to the summary point, obviously you lose part of the transparency of the discussion because then it's not clear who said what. But then on the other hand, it means that you might be more freely receiving the opinion of people because people are not worried that it will be reported sort of quoting their name. Although their name is at the end of the report, but it's not clear who said what. So in a way, depending on the topic of the policy that you are discussing, the meeting report, the format of the meeting report might become different from one to each other. My recommendation is don't miss on documenting the full list of all participants and put it in the report. I mean, as an annex in the end of it, whatever. So that's why I'm saying that, I mean, sort of, even if you limit transparency in certain elements should not be dropped because you lose part of the benefits that you are intending to get as a policy dialogue. And then plan again for timely report. I say plan for it again. Why? Because everybody is involved in policy dialogue is a busy person. Everybody involved is a busy person. Your team and those who come. And then if you have not planned for a free time for the team who prepared the report after the event in advance, what you end up is that you finish the report, but then the report, you finish the policy dialogue, the report is delayed. And that's the worst thing that could happen to a policy dialogue. Not the worst thing. It's a bad thing to happen to a policy dialogue. So you need also to think of who is going to clear the report. The same issue that Mohammed mentioned. So is the Ministry of Health going to clear the report before being released? That might be the case. If that's the case, then what if the sort of the policy dialogue is against what they are going to say? So think about these issues. Certain things you cannot prevent, you cannot change, but thinking about it in advance will help you to document some of the challenges or maybe to alleviate some of the issues that might come forward in the past. Even if you're worried that the sort of the policy owner may not clear the report, this should not become a reason for not having a policy dialogue because there are other benefits you get out of it, especially if it's being used to inform elements of policy development or to inform the challenges in policy implementation, etc. The other issue that I would like to cover, and I'm trying to finish in sort of a couple of minutes so that you have at least 15 minutes for
you have time, Dr. Ash, you have time till 5 past 1.
Absolutely. So many thanks. So the issue would be that the link between policy dialogue and policy brief. Again, I mean, policy dialogue is a tool, policy brief is a tool. Both tools can be used. There are occasions that you have policy brief, not policy dialogue. There are occasions you have policy dialogue, you do not have policy brief. But they can inform each other really well. And if a policy is big enough that requires both of them, then you can plan. As I said earlier in the presentation, so it can be used to identify policy options that will be part of the policy brief development. So it will help you on what to focus in the policy brief. It can be used, policy brief sort of might have been prepared in advance, and then it can become the background sort of document given to the policy dialogue so that people discuss the policy issues that are raised in the policy brief. So you can use it to enrich it, to revise it, to improve the policy brief and its options and different elements of it. And then also the policy dialogue sometimes is conducted in response to a policy brief. So your policy brief is being issued or released, and then there are reactions. People are saying that, oh, it's incomplete, or saying that, oh, we are not going to do that. We agree with you, but I mean, it's so difficult to do, or whatever. I mean, so then the policy dialogue can become a sort of to collect the reviews on the policy brief and bring it forward, so then the documents can become the discussion. So in a way, there could be a very dynamic linkage between policy dialogue and policy brief. As I said, they are as tools, they can be independent from each other, but they can actually talk to each other also really well. Okay, so I stop here. I think this was my last slide. So what I would like to see.
As still, I have 5 minutes, Dr. Arash.
Many thanks. I'm aware of that. So, yeah.
So I mean, you know, there is a hands, on from Dr. Afif.
Okay, many thanks. Yes, Afif, can you go ahead, please?
Yes, well, thank you very much, Dr. Arash. It's very interesting and comprehensive presentation. I would like to share about an experience in a policy dialogue. Maybe it could be classified as such. It's related, in fact, to the depth and importance of research in a clinical master in family medicine curriculum. And it involved both the representatives from the academic world, the College of Medicine and Medical Sciences at Arabian Gulf University, the primary healthcare representatives, CEO, and other head of departments, research committee, quality improvement committee, ethics committee, as well as other stakeholders like accreditation bodies, WONCA representatives, as well as partners like Johns Hopkins University, who are partners in this program. And it was really very fruitful, and it was not easy to reach a consensus and to select the best, the best component and the relative importance of this part in a clinical training program. It was not easy to reach, but finally it was done. And this is an example. Thank you.
Many thanks indeed. I mean, that was really helpful. And also you refer to a major program that has happened as a result of sort of the work that WHO and other institutions are doing, including your institution. And sort of, I mean, within that there are vested interests and there are disagreements, etc. And the policy dialogue could become a tool for that purpose. So I have hands, so from Hala and Mohammed, maybe each one 1 minute, please, maximum. Hala, please go ahead, and then followed by Mohammed.
Thank you, Dr. Arash, for your excellent presentation. I just wanted to highlight the problem. We've been focusing on conflict of interests of different stakeholders around the table, but there's also, from my experience, a lot of power struggle, under the table power struggle. It might not be a conflict of interest. And this could be devastating. So it's very important to understand in the preparation of such an event, conduct a stakeholder analysis and try to prepare as much as possible the share with the expected conflicts around the table and the sensitivities. Mostly it's politically sensitive, and each needs to protect his own turf. So it's more turf protection, rather policy defending policies, certain policies. So I wanted to raise this and to get from your experience how we could do it. I've tried doing it in a way that we separately meet with each of those stakeholders before, to try to demonstrate their importance, giving them to feel that they are the most important one. Each has to feel that they are politically visible, they are their turfs are protected. So there's some diplomatic skills that we need also to take in account. So over to you.
Yeah, absolutely. And in a way, one of the reasons you might have the policy dialogue is because of this power struggle. So you are aware of people are disagreeing because of turf issues, organizational position issues, and you use the policy dialogue so that you make those very clear and people realizing what other person thinking. So in a way, it's a challenge on how to run a policy dialogue, but it's also a good reason for having a policy dialogue. Many thanks, Hala, for raising that.
Yeah, I was speaking about barriers, this ideas of barriers and enablers to implementation of policy options, and how to mostly I'll be talking about how to think about what these are, how to organize your thinking about those barriers, and a little bit about where to look for information on barriers and enablers to implementation of these options, and how to kind of write about it in the policy brief. So first, to kind of just define what are barriers and enablers. I've always actually struggled to explain the difference between these two without just saying that one is the opposite of the other. And there are other confusing, as I think about this, there are other confusing sets of terms to me, like aims and objectives, or discussion and conclusion, vision and mission, inclusion and exclusion criteria. I know there's defined differences between these two, kind of sets of terms in each one, and between barriers and enablers. There are some ways to distinguish, but I've never found that kind of distinction quite clear. I've also always resisted the idea that things that affect the implementation process must either be good or bad, either a barrier or enabler, simply dialing the outcome up or down somehow. Couldn't they also modify the intervention in some way, right? So all change doesn't necessarily need to be kind of, framed as either an obstacle or an accelerator. So what I usually do in most of the work I do, I've done a fair bit of research on barriers and enablers in implementation processes. And I tend to just then speak of them about as factors instead of barriers and enablers, and having different categories or different definitions. So I think a lot about factors affecting implementation. It just feels like a more flexible, way of framing it. That said, in a lot of the presentation, I'll keep talking about barriers and enablers, but just keep in mind that that might be a useful distinction. So what kinds of barriers and enablers are there? I want to start off by seeing if we can have a little bit of interaction, but in a different way. If you could go on a web browser, either on your computer, on your phone, but in a different screen, and go to menti.com, menti.com, and put in the following code here. It's an 8-digit code, and I'm going to ask you to respond to a question, and then hopefully you'll be able to see your responses. So I'll give you just a few seconds to kind of open up something and put in that code. Okay. And then what I want you to do is enter up to 5 different factors that can affect the implementation of policy options, or at least 1 or 2 factors. This is just an initial brainstorm. Enter each one separately, and please use short kind of 1 or 2 word phrases so the screen doesn't get too crowded. And then I'm going to try to watch the and to show you the answers as they're submitted. So let me just do the screen presentation quickly. Okay. I'm going to share a new screen now, so you can see the answers coming up. There we go. Okay, hopefully you see some of the answers coming in from the group. I'll give you a few more seconds to put in some ideas. Okay, great, thank you. you're welcome to keep putting in some comments, but I'm gonna just start making a few kind of observations about the ideas that are coming up. This is a word cloud, so it'll obviously show you the bigger the word, the more people said it. In an example like this, there's lots of different, ways to formulate a factor. So I know that there's difference of opinion and difference of opinions shows up as two separate, concepts, but they're the same. Funding, resources, cost might be similar ideas. I think it's useful to think about the kind of common factors that we most often go to, both because those are often important factors, right? We work in our various fields, but we kind of have an experience of the way health systems and policy work and have a good idea of the kinds of things that typically come up, right? So on one hand, it's useful because it reflects our experience and our knowledge about the system, but it also reflects our assumptions about the system, and sometimes our blind spots or our kind of conventional ways of thinking about things. So, for example, if you look here, culture and political will are slightly bigger. I think a number of people must have put in culture and political will. I think those are really important factors, but there also can be sometimes too easy to point to these factors, but in a vague way. Like, what does political will mean? Does it mean that the government is simply not doing what we think it should do? Or it says it's going to do something but doesn't follow through? It's a kind of a catch-all term that describes a lack of energy or input or drive from the government, but doesn't exactly explain where that comes from. Why is there this lack of political will? There's a similar kind of question I often have around culture. I'm an anthropologist, and I think culture is really critical and a really important thing to understand. But it also can be one of these kind of catch-all terms, right? And in a policy brief, even in the short space of a policy brief, the more specific you can get, the better. Try to think about, for example, what exact kind of aspect of culture, what exact driver of political will is important. And then I think the one other thing I would say about a lot of these are, again, appropriately, they are focusing on either individual kind of behavior or opinion or perspective, or what I think of as kind of the familiar parts of health systems, right? Bad management, lack of resources, poor kind of implementation and organization, et cetera. So the kind of the again, quite important, but also quite common ways that we have of thinking about health systems. And I'm pointing this out because I'm going to shift shortly to talking about conceptual frameworks for barriers and enablers, and how those conceptual frameworks can help us kind of expand and organize our thinking. So I think all of the points you've put up here are really important and very common in key factors affecting the implementation. But they also may be factors that reflect our conventional habits and ways of thinking about the problem. And I want to think about some ways of expanding that. Great. Okay, so I'm going to go back to the slides now. Okay. So we've done a kind of discussion on those barriers and enablers. And what I'm going to shift to is to start thinking about, how do we think about barriers and enablers? What are the concepts, the frameworks, and the theories that we're going to use for this? First thing to say is that lists of barriers and enablers, you can often find them in primary studies. And many times they're developed inductively from the data, and often presented as a bullet point list. So, someone goes and does research on an implementation process and comes up with a bunch of kind of ideas. In other cases, researchers or policy brief writers can use an existing conceptual framework to collect, to label, and interpret information on barriers and enablers. And there are now many, many frameworks available for identifying and organizing factors affecting implementation. I don't think this was true 20 years ago. The field of implementation science has grown quite rapidly over the last 20 or so years. And now we have many kind of frameworks for thinking about implementation. I'm going to show you, there's a link in that slide, and I want to show you what the link takes you to. This is a website from, I'm actually not sure the organization, but it's a list of dissemination and implementation models, DNI. So this includes both the implementation of policy options, like the kind of question, but also the dissemination from research to policy, right? And the kind of movement of evidence, kind of across those fields. And you can see, I'm not going to, there's many dozens here, but they have, many of them have their own particular name. If you go on this website and click, each one, you'll get a kind of breakdown, including key constructs and the kind of core citations and examples. You'll see which part of the socio-ecological model it looks at, and then what field it comes from. Some of these are quite specific: sports injury prevention, health psychology. Some of them more general, like public health, participatory action research, policy. So you'll see that there are, I didn't count them, but there's maybe even close to 100 models here. The WHO has its own list of implementation science models as well, as does TDR and several universities. There's no shortage of kind of frameworks out there for thinking about implementation and the kind of ways that that implementation gets affected. I even found a model of implementation models paper in the journal Implementation Science. So there's this paper that's it's making sense of implementation theories, models, and frameworks. And it proposes 5 categories of theoretical approaches. So this is the model of models paper, just like you have systematic review of systematic reviews, or systematic reviews of systematic reviews of reviews. So lots to kind of work with and learn from in the field. Some important points I want to make about these models, though. Keep in mind that every framework is a simplification or a reduction of a complex real world, right? And so we'll always leave potentially important ideas out. I often hear, both among my students as well as with professionals and faculty and policymakers and researchers, that a model has a problem because it leaves out something, doesn't account for X idea, or whatever is of interest of me, Sometimes that's a weakness of the model. Sometimes the model really does have a blind spot and should have included that idea. But oftentimes that's not what the model was designed to do, right? It was trying to take one piece of a complex world and map it out. That doesn't mean that there aren't other factors in the world. But the bigger a model gets and the more factors that are kind of included in it, potentially the less useful it becomes. It may become more accurate, a more faithful representation of the world, but it also may be too unwieldy to kind of really make sense of, or to use feasibly. So the simplification of models is a really important part of it. Frameworks are usually designed, and this applies to models, any kind of model, right? Not just for barriers and enablers to implementation. Frameworks are usually designed for a specific problem, context, or process, right? So you have a model about knowledge translation from one domain to another. Many of you have probably heard of diffusion of innovation, which was an early kind of model for implementation. There's the normalization process model, for example, and many others for thinking about how a new intervention gets institutionalized and integrated into operations. Models for organizational change, at the organizational level, for motivational change at the individual level, complex systems dynamics, and on and on and on, right? But every model has a particular purpose and particular focus. Many frameworks contain similar ideas with only minor differences. So if you went back through that list of, nearly 100 models, you would find a whole lot of similarities between them. And that's fine. Sometimes these models get branded, they become, become competitive. Someone has their model and someone else has a different model, and one is arguing that the other is better. But in many cases, these ideas are not that different. It's quite refreshing when a model comes along with a genuinely kind of new idea. So don't get too tied up also in the kind of smaller differences between models. And then when you're working with frameworks or models, you should feel free to modify or combine them. We can have a discussion if there's interest in it in whether a model can be evidence-based, or in which way it's kind of based in evidence, and when you can modify it or not. But in most cases, frameworks I think of frameworks as heuristics for thinking about things. It's a cheat sheet, a kind of a useful way of organizing my thinking, rather than some kind of truth that's been captured and can't be changed. So I think it's quite important, depending on what your purpose is, right, to look at the frameworks that are out there that have been used and seem to be useful representations of the world, and then put them together in ways that are appropriate for your task kind of in front of you. Finally, conceptual models are different from theoretical models, though the two are often confused. And we're going to have some discussion about that just now, but I think it's useful to understand the difference as well when working through both doing research and then trying to interpret research and do a policy brief. So let's dig in just briefly to this kind of question about concepts and theories. Could I just hear from the group, just either unmute yourself and jump in, or in the chat, what's the difference between a theory and a concept? We'll leave the framework part for a moment, but what is a concept and what is a theory? I tell my students when I talk about this that I'm positive that you all have used these words quite often, right? And so have a sense of what they mean. But do you have a way to kind of define them?
Actually, if I can jump in here, a theory is usually the overarching pictures which show us the connection between different concepts. Okay, great. So there's something about it being overarching and showing connections between concepts. Yeah. Anybody else? What is a concept? Theory can be, there's a comment in the chat, theory can be scientifically thought, while concept can be more general idea. Okay. So a concept is I think the key thing there is that a concept is an idea, right? It's the name we have for a phenomenon, an idea, a process, something out in the world. We give it a name.
we see that there are lots of different examples of that. So we say it's part of a category, right? And we kind of call that a concept. A theory, we talk about overarching, the comment here in the chat says about it's scientifically thought of, it's a principle, it connects things. A theory connects things, but it doesn't only connect things. A framework connects things. If you look at the slides, right, we've got this ecological model or the socio-ecological model for obesity intervention, for example. Individual, interpersonal, organizational, social, society, community, society, right? Each of these 5 words is a concept, right? Society is a concept, the individual is a concept. And the framework shows us how they relate to each other a little bit, right? And there's an idea that they're nested within each other. If you look on the right, there's an even more complex one, right? It's based off the socio-ecological model again, but within each ring, there's lots of specific ideas. And those ideas also are presented as mattering. You know, there's a number of health service concepts that matter, a number of family concepts that matter for whatever health problem we're looking at, right? And this is a framework, right? It brings these all into some kind of relationship to each other. It provides a frame for kind of how to organize them. What both of these frameworks do, what both these frameworks don't do, is to explain anything. They don't explain how you get from interpersonal to organizational or vice versa. Doesn't explain how domestic disputes and racism relate to each other, right? To look in the other model. And coming back to that idea of connection, where a theory kind of connects two concepts, it not only connects them, but it shows the mechanism, right? It shows how you get from one to the other, exactly what it is that brings those things into kind of association with each other. So a theory, what I usually end up saying is that a concept is an idea. It's a name for something that we have. A framework might bring those things into relationship with each other, but a theory is an explanation. Right? It explains actually how this barrier works, for example, not just merely that it is a barrier, but actually where it comes from, right? Or how intervention works, a theory of your intervention or a theory of change, right? It's an explanation of how it works, not just the key components of it. So I think this is it's a useful distinction, and I'll show you why kind of as I go through this. I want to take you through a few frameworks now, and the first one, let me get here, is something called the Shure Framework, the Shure Conceptual Framework. It's a framework for identifying barriers and enablers or factors affecting implementation of health policy options or programs. This is something that I've used in a number of reviews that I've kind of worked on, a number of qualitative systematic reviews. And I'm just going to briefly show you kind of the core content in the framework. In this first one, we look at, this is essentially an individual level. We've got recipients of care, providers of care, and other stakeholders, which can be everybody else. And in each one, you know, there's a specific subcategory. And here we have, for each different type of person, knowledge and skills, attitudes about acceptability, appropriateness, credibility, and motivation to change. Right? So we've got 3 kind of interpersonal or intrapersonal psychological kind of features, factors, for these different types of participants. Then it's got a section on health system constraints, and it's got a long list here: accessibility of care, finances, human resources, training, supervision, communication, authority, accountability, on and on. Right? You can see there's a long list of factors there. And then it's got a short section on social and political constraints. Ideology, governance, short-term thinking, contracts, donor policies, influential people, etc. So we use this framework. We've also expanded it. So in the reviews that I've done, we took the framework, but one of the things we immediately kind of felt was that this was insufficient. For example, in social and political constraints, these are all important factors in the social and political context, but they're far from the only things that matter, right? And when we were doing the review, we thought, well, we could spend our whole lives trying to add concepts that matter from the social and political domains. We know that this list is too short, but we can't have an endless list. So let's look at the studies, the review questions, let's look at our evidence and try to figure out if there's some factors that are going to be obviously quite important and should be brought in. And so we amended the framework based on kind of the evidence that we were working with and what seemed to be relevant. We had similar concerns about health system constraints. This is just kind of a long laundry list of some problems, but certainly isn't comprehensive. And so we removed some and we added some that seemed to be missing. So this was a useful way of organizing our thinking, right? We were using this framework to do a review on factors affecting a policy. And it was essentially once we had modified the framework, it became a template for extracting data from our underlying studies when we did the review. So here's an example of how we did that. In that first level, among the recipients of care, we've got this idea that knowledge and skills matter. And this is the summary kind of data that we extracted from some of the studies, right? So this is the specific factor, finding that came from the studies. And here is the more direct link back to the two studies that, gave us this finding. And we also made space for possible solutions. Did the research, suggest some solutions to this problem as well? So, yeah. So that's how we used it in the review. You can also use this kind of framework in developing a policy brief. It may be a more rapid or kind of shorter process in some ways. It may be less in depth than a full-on systematic review, but you can use a framework in this kind of table to organize the kind of work that goes into the policy brief, right? And those tables that identify implementation issues and strategies. So what about theory and theoretical frameworks, and kind of how are they different? We've talked about theory. That theory is a explanation, right? Rather than just a naming and linking of ideas. So I'm going to show you just some simple basic theoretical frameworks so you get a sense of how they might look different. This is a very familiar one, probably. This is the kind of linear development world idea of how development or health policy work is supposed to happen, right? You put in resources at the beginning, you have activities, those create outputs, outcomes, and impact, right? And there is a kind of series of if-then statements that links us in a linear kind of logic model. I imagine all of you seem to be quite experienced in your fields and know that rarely does life, play out this way, even if it would be nice if it did. But this is a kind of an idealized, kind of model for how you get from A to B, right? What are the steps from A to B? This is a theoretical model from health behavior change kind of theory. This is, I think this is the social cognitive model, if I'm remembering right, but this is not my field of expertise. But this is a model that says, well, how does behavior happen, right? Well, in order to have behavior, you have to have an intention to act or a decision not to act. Where does that intention come from? Well, it comes from three different things, right? An attitude towards the behavior, a subjective norm, pressure to act, and your belief about your ability to do the behavior. Right? Well, where do those things come from? Right? And so we keep tracing back, where things come from. So this is different than a conceptual model because it shows that how things are linked, right? It says that behavioral beliefs are not merely important, but they specifically shape attitudes. And they don't shape subjective norms, and they don't shape behavioral control, because those are different things, right? Behavioral control comes from, prior beliefs about self-efficacy, for example. So this is really starting to kind of unpack and try to show how things are connected rather than just putting them in categories and saying, these things matter. So this is a health psychology one. This is a model of path dependence, right? So this doesn't exactly show you how you get from A to B or from B to C, but it's a theory about if you find yourself, you or your health system find yourself in the state of being in B1, right? If you find yourself in this category, it can be really hard to get to C2 if that's your policy goal, unless you find some way to track back, among these prior options. It can be really hard to try to, I'm in the US right now and teaching students about the health system in the country. And they say, well, how can we get from private healthcare to publicly provided healthcare in the US? And I say, well, it's really difficult because our entire system is set up around private care. And our schools, for training clinicians are set up in that way. And our insurance systems are, and our jobs are set up to support private care. And the government can't just decide it's going to start providing private care. It's got to be, kind of undone somehow, or we have to take path dependence into account. So this is a model for kind of representing path dependence, for example. And a couple more I want to show you. It's often useful to think about change in a non-linear way, especially implementation processes, which can be quite complex. And there are interesting models for this. So even just the simple idea of feedback, that when you have an outcome C, for example, that can feed back and have an impact on a previous factor on B, right? And those can be mutually reinforcing. Sometimes that feedback is bad and sometimes it's good, but not everything goes from A to B to C in a linear fashion. And we need to think about feedback loops and when they're kind of useful. Emergent behavior is this idea that systems often organize themselves. There's kind of self-organizing behavior, and that's often good, but it's hard to manage. It's hard to kind of direct, but you can support it, right? So when you introduce a new type of health worker into a professional team, or a new type of task into a team, often it's impossible to direct exactly how that new person or task is going to be integrated. The system itself kind of evolves and organizes a response. And you may need to think about how to support that self-organizing, that emergent behavior, rather than trying to direct and dictate. And finally, we have the idea of a phase transition, right? Which is the easiest way to remember this is from physics, where as water cools, it gets colder and colder and colder, but doesn't change its properties. And then all of a sudden at a certain phase, it freezes, right? And becomes hard. And so in an implementation process, you may have these periods where there's not much change, but then there's a rapid change in a particular direction. And understanding that is really important if you want to tell people, how is this implementation going to roll out, and what kinds of stages should you be prepared for, and how should you, address each stage differently. And then finally, this is one of those models that's more squarely in kind of implementation science models. It's a multilinear or slightly less linear, because it says, at the bottom we have a process. The process has lots of different, cycles within itself. let me just take you through hopefully you've been following what I've been saying. I'll just link the visuals to what I've been saying. These are the two conceptual frameworks that I was pointing to. And they're conceptual because they organize the names for things, but they don't show how they're connected, right? Then I went through the Shure Framework, which is just a kind of an organized list of factors affecting implementation. These are the individual ones. These are the health systems ones. There's lots of different ones here. These are the social political ones. And I talked about how we modify those, right? And this is the way that we use that framework to kind of extract information from underlying studies. And then for theoretical frameworks, this is the linear one, right, which is very linear and kind of logical, but often doesn't represent reality. This is a health behavior model. If you want to understand how to get staff to change your behavior, you might use something like this. This is an illustration of how path dependency works, and that it can be hard to move from, you know, the state of being in B1 to, you know, D1 or D2. And then these are some of those more complicated models that show that change often doesn't happen in a straight line. There can be feedback loops. Behaviors often emerge without you kind of directing them. And you can have sudden changes in states called phase transitions. So did you all follow that as I went through? Could you see the changing graphics?
Yes, we can.
Okay, all right, great. And then this is a final one from implementation science that looks at all the different things and how they kind of sit together to affect an intervention. So, okay, now let me just confirm. I've got until 10 after. Is that right?
Yes, Colin.
Okay.
You have still 10 minutes.
Okay, let me just take you through then just some final thoughts about these models. When you're thinking about a model for barriers and enablers to use in a policy brief, you should look for frameworks that are fit for your purpose and contain useful or relevant prompts for naming, connecting, and explaining phenomenon, right? So either the conceptual piece and or the theory, and then adapt as combine as needed. So I'm wanting you to feel like you can kind of explore and be flexible. The evidence that you're reviewing for your brief, either primary studies or evidence syntheses, may also contain useful frameworks, right? I've shown you a list on a website of a bunch of frameworks, but the research that you're looking at may also contain frameworks that you can adapt. But again, as with all aspects of a policy brief, the shorter and simpler, the better. And complexity is rarely more useful than simplicity at the end of the day. So this is just a kind of a plea to be flexible and to be simple. Where do you find evidence on barriers and enablers? Come from a lot of different places. Comes from quantitative studies, especially quantitative process evaluations that might collect data on, you know, factors involved in implementation. Often RCTs of complex health system interventions, if they're well designed, an RCT might even be collecting data on the kinds of things that affect implementation. We find a lot of evidence in qualitative evidence syntheses. This is what, you know, a kind of real strength of these reviews. We can't quantify the effects of a factor, but we can point to the idea that the factor probably matters and how it works, where it comes from, how one might change it. Similarly, primary qualitative studies often have that information, and just local experience of the people involved in the kind of policy making can be useful. Don't be afraid of what appears to be indirect evidence regarding barriers and enablers. And I don't think it's really indirect, but it may feel like that. an implementation process, the work of rolling out a policy option and kind of getting it, taken up, is its own distinct phenomenon and is not necessarily specific to the health problem or even the type of intervention you're looking at. For example, if you were doing a TB screening program, or you were doing a home-based cancer hospice care program, and both of them used community health workers, right, from the area, with not a lot of training, not well paid, whatever the kind of problems are, or whatever the features are of that program. Those two very different programs might face very similar factors affecting their implementation, right? So when you want to think about implementation, don't just look at the evidence for the particular health problem that you're looking at. Think more about the think a bit more broadly, right? And look for evidence, even not in your particular policy option, right, which might be a hospice care program that uses community health workers. What is directly relevant to the implementation is probably more going to be the community health worker piece than the health problem itself. And then I've got a final section, which I'll take you through just briefly on how to address barriers and enablers. Ideas for strategies to address implementation barriers and enablers may come from, so where do you get these ideas from? They come from the evidence that you review. They can come from other literature, especially studies or theories of change, or from your own experience and intuition. And I think that in a lot of policy briefs, a lot of the strategies for dealing with implementation problems just come from the air, come from people's intuition, common sense, whatever. Strategies may try to mitigate impacts of existing barriers, or may try to transform or remove the barrier. This is really important distinction, because say you're dealing with stigma, trying to mitigate the impact of stigma on individual people is an entirely different task than trying to get rid of the stigma or to reduce the stigma. They're two very different activities. So when you're trying to address stigma, for example, it's really important to think, are you trying to reduce the effect of stigma on individuals, assuming that you can't change it, or are you trying to actually change stigma in some way? Strategies can also focus on more upstream or more downstream approaches. And yeah, and that's again, a kind of balance you have to strike. And then make sure that the strategies that you're suggesting are not focused or framed as a goal instead of the process. So for example, if nurse attitudes are identified as a barrier to implementation in your program, don't suggest that improving nurse attitudes is a strategy. Improving nurse attitudes is the goal, right? That's going to be what's going to get you, a better outcome. The question is, how do you improve them? How do you change attitudes of healthcare workers? That's what you need a strategy for. This is quite a common kind of mistake. So just to keep that in mind. And ideally, I mean, this is maybe something also for a discussion. Ideally, I think your questions should strike a balance between downstream mitigating approaches, which are quicker to kind of put in place, more feasible, quicker results, and upstream transformational approaches, which really get to the heart of the problem. So I think of it as a balance. And a couple more points. A real dilemma, especially in something like a policy brief, is finding strong evidence on how to successfully address barriers and enablers in your policy brief. So we're getting a little bit kind of in the weeds here, but you have a policy brief, you want to put policy options on the table. You also want to think through the problem of, if I do this policy option, what challenges am I going to confront and how should I address those challenges, right? That's all part of your kind of work that you're doing in the policy brief. But how do you know what is going to be effective at addressing those challenges? How do you know, where do you find those strategies? Keep in mind that strategies that are recommended in primary studies or reviews that are informing your policy brief they may not be evidence-based. They may just be the whim and personal opinion of the writers. That doesn't mean they're not good ideas, but that's not the same as being evidence-based and kind of tested. The challenge, though, is that reviewing this evidence properly would usually be a very different research task from the one guiding the overall policy brief. For example, if your option was a community-wide TB screening policy, right? Implemented with community health workers, but we know that community health worker motivation is a challenge in many countries. So to how do you change motivation? How do you increase it? That's a whole long question about which people have written, many, many, many papers and books. And that's probably not a feasible kind of set of questions to try to dig into directly. So I think it's important to recognize that you're also going to find yourself at a limit about what you can do, I think, in a policy brief, once you've gotten to that kind of strategies for addressing challenges, that kind of stage. And so my last kind of point here is that it's important to be clear about where your ideas for strategies come from, and acknowledge the strengths and limitations of the strategies you recommend, and the kind of evidence on which they're based. And I think it's useful to frame these as potential strategies for addressing implementation challenges, but then make it clear to those reading it that they need to review these strategies and adapt them for local contexts and resources, and really, think through, is that going to work, in my setting? So, and that, I had an exercise, but we're not going to have time for that. But I'm happy to take questions in the Q&A section. Okay, thank you.
So I'm going to one of the final stages of any planning approach, so that thinking of how to monitor and evaluate. And then we are linking that with the policy of development and seeing how it can be done and whether it should be done or not within the policy picks, etc. But before doing that, as usual, so I go through some key introduction so that we are all at the same page. So it will be some discussion on what to be monitored and about the elements of it, and how to also evaluation and also agenda in phase 3. So I'm not referring to this slide, I can save some time here. Okay, the first thing is that just a reminder on the definition on monitoring and evaluation. So there are many definitions, but the definitions. But the main thing is that for monitoring, we want to see whether we are doing what we are supposed to do. So in a way, it's following the action. So it's very much focus on the processes, whether they are happening at the time planned for or happening the way that they were planned. So in a way, it helps the manager to see the program is being followed as it's been designed. Evaluation asks a different question, is that whether the program has resulted in what it was meant to result in. So in a way, we look at the sort of the outcomes of the expected outcomes of a policy or a program. And these outcomes could be of different nature and different levels. But then basically whatever has been planned for, so we want to see the outcomes here. So in a way, it looks at it in the language we call it the summative approach. While the monitoring will be a formative approach, which is helping you to form and improve and making sure you are on track. While in evaluation, you summarize, you get to a conclusion whether the work has been done or has resulted in what it was supposed to result in. There are other terminologies. I'm not going to read this text. So this is a nice text I found in one of the reports of IOM. And sort of you can refer to it as you can have it as a slide, but the terms are review, assessment, for example, appraisal or audit that are being used, and they're being used in different meaning in different texts. So one key question is that whether we should have a monitoring evaluation section in policy brief. As you may recall from our proposed format for policy brief, the template, we are not suggesting it as a must. We are actually saying that consider doing it and having that. But then to be able to look at it from that angle, we need to see how M&E is also being looked at in general. So first, I mean, again, similar to what I said about policy dialogue, there is a wider meaning for monitoring and evaluation. So there are reports. The title is How to Do Monitoring and Evaluation, and the report is maybe 200 pages, 300 pages. They're actually looking at the whole cycle of project management or program management, and they use the sort of monitoring and evaluation as the way of sort of incentivizing the teams who are conducting the work, to giving them the resources they require, and also to assessing their performance. So the whole package goes under monitoring and evaluation. Obviously, we are not talking about this. We focus on the key principles, not the management cycle itself. So that's you need to bear in mind. So, and then when we talk about inclusion of that in the policy brief, what we refer to is actually whether, I mean, sort of addition of elements of monitoring and evaluation will help policymakers in making better decisions on how to monitor the implementation of the program. So whether, I mean, it would add to that essential knowledge at the level that the policy brief is required to provide. The other reminder here is about the policy stages. So you remember the 4 stages. So you've seen this slide so many times. I apologize for that, and they're coming all after each other, but it's important. The last stage is policy evaluation. So in that sense, that's the sort of the context. So when we think of it that way, then in a way, we are, as part of our planning, we are thinking of how it should be considered. And for that, I mean, we need to think of what are the indicators. What are the performance outcome indicators that should be measured, how they should be measured. And then when you do policy evaluation within that, you report on performance and outcomes. And then if you think of the 4 stages of policy making that are always seen as a sort of cycle, means that, I mean, the evaluation outcome will help you to revise the policy itself, change it, and do it better as a result of the evaluation outcome. So in that sense, this part of the policymaker is going to do anyhow, and we did this or supposed to do anyhow, and it's going to be seen in that light. Okay, so for the inclusion of it, I mean, first of all, I mean, the first thing I need to say, most policy briefs that I've seen, and most policy briefs probably you have seen, do not include such a discussion on monitoring and evaluation. Is that a limitation, or is that a good thing? So my question to you is that should policy briefs include a monitoring evaluation section consideration? So should they, I mean, you remember it should be brief, should be short, should have, I mean, focusing on the key issues. Is this considered from your point of view a sort of a must? So first of all, as before, I'd like to see a show of hands. I don't know how to make this work so that I see the hands. How many of you thinking that monitoring evaluation should be included in policy brief? And then if you you think yes, then what are the reasons you are providing? So can you use the chat box for that purpose, please? Okay, and Mohammed, maybe you add why probably it's better to include the father. And can you also add your whys? So Guillaume mentioning sorry, I'm a bit sort of lost with that comment. I don't know whether it's relevant to our session or not. So criteria should be there. I see that from Rajiv as well, from Gohar. Can we guide policymakers can be referred to, but concise, of course. Oh yes, thanks, Leon. It's not noted. Process evaluation, Ahmed, thank you for that. Yes. So there are many colleagues saying yes, but I don't see the why. I guess you all assume that it has to be done anyhow, so it doesn't need documentation or a lot of arguments. So I see from Pi suggesting that maybe not yet in policy brief, but maybe you can add it in policy implementation framework. So that's the point. So then, so maybe you want to explain why not. If anyone's saying no, or being not being sure, but a bit more towards a negative, why do you think you should not be included? So one good reason could be because, for example, it has you have limited space for the discussion. That could be a good enough reason. But to me, because I mean, you are dealing with a short document anyhow, and you are saying that everything is important, then we need to have a better argument for that. Okay, very good. So I see a hand from, I think it was Muhammad, if I'm not mistaken. Do you want to go ahead, Muhammad? So maybe in 1 minute.
Yes. Yeah, just to elaborate, sorry, just to elaborate more on the importance of discussion. Sometimes the policy brief writers or experts need some space to elaborate or to add some insights or reflections on the idea that need to convince the stakeholder, because the results and the other objective of the policy brief sometimes written in a rigid way or in a more scientific way. So you need a space just to add your flavor and your reflections in a way that use the local context and the local dynamics and politics and something behind the facts, let me say that, because you know there is no one reality in such issues, so we can add more in that space. So really, for me, I would prefer to use it unless the targeted policy makers need very concise and scientific language in writing the policy. So maybe I would not use it. Thank you.
Thank you. I saw Ali's hand as well. So do you want to go ahead, Ali?
Yes, thank you very much. So basically, I think that it is good to mention it in the framework, but I think that's not the main gist of the policy brief. You want to sell the idea basically on that. So that doesn't mean monitoring and framework that much. However, I think it's good to have an annex as a framework, monitoring and evaluation as an annex. And another important point is that because we want to have at the final stage, this is a cycle of evaluation, and we want the results of that evaluation to feed into the next cycle of our policies. So that's also important to have some kind of evaluation at the end of the policy in order to, you know, maintain that cycle. That was the framework that was mentioned also in day one. So in short, I think we have to mention it, but not elaborate that much to be concise, but have it as an annex. But it's important. Thank you.
Many thanks indeed. In a way, also the point becomes that, I mean, just bear in mind, we are not talking about the full framework here. We are actually talking about a very concise element, as you have referred to, in a way highlighting the issues. One other argument I see between the lines colleagues are making is that, well, I mean, sort of the options are not yet selected. Developing a monitoring program is time consuming. So in that sense, I mean, we rather to know which option is selected and then develop it on that one. That could become another argument here. So maybe I also ask Sultana, maybe if you want to raise a short comment here, please.
Sure. Thank you, Dr. Arash. In my opinion, it should be included, a monitoring and evaluation section, because by the end, we wanted to advocate for an evidence-informed policy making where evidence should be utilized throughout the policy making process, which part of it is the monitoring and evaluation. And including this part of monitoring and evaluation will allow us to come back easily later and modify our options, and as by evaluating it and see if we have made the wrong choice and how we can make the correction from there onward.
So I see also Afif's hand, but maybe Afif, I invite you at the later stage, so then you can add both comments at the same time. just I refer to, I mean, a short statement also from Gohar. I think that was a good summary, is that perhaps you don't need to develop a detailed monitoring and evaluation plan, but you need to at least mention how the policy would be monitored and evaluated. So that's also a good look at it. And then the sort of similarly, Sebastian saying that general M&E consideration should be included. Okay, so let's continue the discussion and then open up again for comments from colleagues later on. So in a way, I mean, about the key steps in policy M&E, the policy monitoring evaluation. The first question is it necessary? I mean, it sounds a bit arbitrary or maybe unreal when we say the fourth element of every policy is evaluation. Then it's asking this question. In a way, we are talking about a plan, detailed planning here. And sometimes you may not be sure that it can help. I mean, it could be possible. So, but it's important to justify very well why it's needed and why it's important, for example, based on the outcome that you're interested, etc. That would also help you to focus on the right indicators and plan for that. What to monitor? I mean, the indicator you need to. So what I mean, what objectives you want to monitor and how to measure it using indicators and what sort of data you need to collect and how to collect that data. So in a way, then it becomes also epidemiological methodology. So to define indicator properly and then to develop a data collection program that would respond to that. So I come to the challenges of this later on, but these are the principles that most documents refer to all the way. What you need to be careful about is that there is an opportunity cost. I'm using the discussion, the language we used yesterday about opportunity cost. So conducting monitoring evaluation takes time, takes money, and it should be in par with the project itself. Sometimes you see the monitoring evaluation programs are actually taking more time or maybe a substantial time from those who run a program, and it results in their efforts to be deviated from the actual work just to report on the work they are doing. And we see that in many organizations that the evaluation or monitoring programs become actually heavy. And by becoming heavy, that means you actually divert from the main efforts, or you then have to pay a lot of money to others to help you, and then the proportion of cost going to that may not be that helpful. So we need to be really careful on that. It should help and add on rather than becoming a burden on the program. Okay, so I'd like to go to a sort of a very old story, and some of you, maybe all of you are aware of. I mean, so the crow and the pitcher. So I just remind you of the story if you don't know that. So I mean, there is a crow who is very thirsty, and he finds a pitcher, a jar, and then there is some water in it. But then he tries to drink the water. It's not possible, so it's very low. What's the solution? Finding some pebbles, dropping pebbles into the pitcher so that the level of water goes up. And then he gets what he wants, which is the water that he needs. So that's the program. So that's the thing that is happening. So I'm going actually to use this to discuss sort of indicator selection for monitoring evaluation. As I've quoted here, I've used this example from a presentation from USAID and the Stop TB partnership programs. I found that really interesting for the purpose. And I adjusted it for the discussion we are having. So the questions are, I mean, sort of, I'd like you to mention, I mean, what are so the answer to this question. So what is crow's objective in here? I would say, I mean, very clear. So to drink some water, perhaps, or you might say to relieve himself from thirst. In this case, what would be the activity? How do you define the activity? I don't know how to make this interactive, but maybe, I mean, if you don't mind sort of putting in the chat quick responses, I think it would be good to get that going. So the activity, for example, or maybe I stop for a second, answer these questions. I mean, put in the chat. What would be the activity? What are the inputs? What are the outputs? What are the outcomes? What is the impact? Maybe 1 minute. Let's continue with the discussion. So, I mean, the summary responses, I mean, exactly as you colleagues have mentioned, objective to eliminate thirst, dropping pebbles. Inputs is pebbles, but also the crow himself and the pitcher, because that you need that to, although you may not need to measure it again. And Zahra, many thanks for your responses. Output, number of pebbles dropped, so and can be easily counted, I assume. Outcomes, water level rising, or maybe crow able to drink, and impact being satisfied with the sort of with the water, perhaps. Yes, many thanks, Shahzad. I think that's well written first question. So then what are your indicators for each one of those? So, I mean, I'd like to highlight activity, outputs, indicators, outcome indicators, impact indicators, maybe. How do you measure this? In a way, in this case, it's very easy, so I'm not going to spend too much time on it. So in a way, in terms of activity and perhaps outputs is counting the numbers, and outcome seeing the, yes, as Mohammed, you have mentioned, water level raising, so you can measure it or observe it. So I mean, and level up test as an impact, so to measure it also, there could be a subjective way of measuring that. So, but my main question is later on. So now we have, I mean, these outcomes coming, I mean, in a way, it's a good example to differentiate between different levels of measurement that you are doing. So my main question here is from you, is this one. So which one of these sort of elements are related to monitoring, and which one of them are related to evaluation? Anyone wants to take the floor and respond? I mean, I have one raised hand, would be really helpful. The chat who responded, so Mona also added comments. Many thanks, Mona. So, so remember the question is about. Okay, thanks, Edina. Activity and inputs are related to monitoring. Output, process evaluation, outcomes, impact. Level of water rating. So I want to Shiraz, you disagree on that sense. Okay, very good. In a way, I would sort of, I mean, personally think that, I mean, because of outputs are towards the end of the process that is happening, I mean, sort of, in a way, I would agree that in this case, they are more closer to evaluation because of the end. But the nature of it actually is similar to activity, because of, I mean, so the way it goes in this case. So let's use this case and then go to some, I mean, more overarching messages from here. So first of all, I mean, what we saw here, sometimes similar indicators can be used to answer in the sort of monitor and evaluation. So I mean, that's a good situation, identifying indicators that their measurement can actually help both elements. But then they may not be the best ones, or maybe. So I mean, the most important thing here is that to ensure that the crow is not thirsty anymore. But that's probably the most difficult to measure anyhow. So then the issue of sort of selection of the indicator, it becomes important. And this could be also one of the reasons that you may be going sort of, I mean, making certain decision about your monitoring plan, what to measure and how to measure it. So most often, however, what is the case is this one, that the indicator is the value for monitoring, so showing how it works. And look at your organization, look at your office, the things that you report on, the things that you collect data on. So most of us are very regularly monitored in terms of how much money we spend, the expenditure, how the money is going around. But the money expenditure is not what is meant to be. Staff members in most organizations are monitored about their presence in the office, so what time they arrived, what time they left. So that's monitoring. But that's not why you employ people to be in the office. You employ people to do something, but measuring what they've done it, especially what quality they've done it, is more difficult. So that's the one that we are not looking at as much. So these principles are really important, I mean, sort of to consider when we are thinking of monitoring evaluation. For example, in the WHO, we have a policy about sort of travel planning. So travel should be planned, or at the tickets and financial aspects of it should be done certain days before the travel, depending on the type of the travel. And then because it can be measured easily, that's one of the things that we always report on it very regularly. We look at it. But then that's not the main reason people travel. And that's not, sometimes also may not be the best thing to measure because, for example, I mean, sometimes, I mean, not right now because of COVID, I mean, the travel situation has changed. But previously, sometimes if you bought a ticket a bit later, it was actually cheaper rather than more expensive. So in a way, it could have become financially better for the organization in certain cases. So that shows, I mean, the dilemma that we always have in terms of what to measure, how to measure it, whether it helps the main outcome or not. Okay, so I'm coming to the specific question. Remember the case we had yesterday, the policy options about increasing ICU beds or within sort of by increasing the number of beds within the hospital that already have ICUs, or establishing new ICUs in hospitals without. And the third policy option became increasing access to medical oxygen in non-ICU hospital wards. Okay, so I'm ready. So let's say you want to monitor. So this is your policy options. Think of each one of them, or all three, whatever. You want to monitor progress with this policy option. You want to add this element in your policy brief. Try to answer these 4 questions. What would be the source? What would be your indicator? And then based on that, what would be the source of data? How to ensure the data collected is useful, valid? What would be the timeline for collection? I mean, so how often you collect this data, and how to use it for your decision-making processes. So I had mentioned 5 minutes for this task. I don't know, 5 minutes maybe could be too long. So maybe 4 minutes. So please, so you have 3 to 4 minutes. Think of the question and then put your response in the chat box. So I repeat the question again. What would be your indicator? Select 1 or 2 of the policy options. What would be the indicator that shows you, that enables you to monitor progress with this policy option? And try answering those questions for that indicator. Just I'm reminding colleagues, so remember the context. This was in response to COVID-19. So hospitals are under pressure. You are doing something for it as soon as you can, and you want to see whether what you are doing is doing it. You are monitoring your progress daily basis, or in a way that, I mean, might be ideal if you have a good linkage of data, but I mean, usually what happens is that it's not done really. I mean, 1 year annual doesn't work, daily doesn't work, referring it to a research doesn't work for this particular policy. I mean, you really need, if you are thinking of monitoring, it should be something that would really help the policy making. So bed occupancy rate, I mean, might be a good thing. I mean, let's discuss some of those options later. So let's say you look at the ICU bed occupancy rate. One of the reasons you wanted to have this is that to reduce pressure on ICU. Okay, fine. But you know that the bed occupancy rate will be very much affected also by the wave of the virus. So then it may not reflect the situation. Counting the number of ICU beds in place is good. There is a challenge there also. I mean, also probably that's probably the best activity thing that we want to monitor. Whether the sort of, I mean, the bed is also being used. I mean, whether the hospital, are, as soon as they buy the bed, they are reporting, or whether it's been actually used properly or not. So then you need to think of how that becomes a valid thing. You might think of, I mean, the patient outcome. Perhaps none of you, I guess, mentioned that so far. But then that's not a good monitoring effect, because that's something you probably look at it when you get to the evaluation. So let's go to the next slide. I'm asking a similar question, exactly the same question. So maybe 3 more minutes, try to answer that for evaluation. And then think of the source of data. And think of the policy itself, COVID-19 policy. People are dying. You are really worried. You are under pressure. Everybody's talking about it. Maybe your relatives are knocking on your door asking to find them an ICU bed for someone who is critically ill, and they cannot find the ICU bed. You all remember such stories. in the peaks of the pandemic. Okay, occupancy rate by type of service, I mean, yeah, could be. I mean, sort of, in a way, I would be a bit worried about such an indicator to how to interpret it in the context of the question we have in mind. How to use implementation, identify the cost effectiveness of different options. Wow, I mean, that's really good. But then again, for that, we need to think of what would be your cost elements, the main cost elements, and what are your main effectiveness elements. So you need to define those, and then you collate them in the cost effectiveness approach. Financial is very important for balancing good requirements. Yeah, I mean, let's think of it. I mean, think of again the situation we all remember in the COVID. So, I mean, sometimes the policymakers, they actually reported in terms of, or ask for the reports about how many beds have been ordered, how much money has been spent for such purposes. And then probably as a policymaker, because I mean, people who are in charge of those programs, they in their power is that to ensure that they are approved. The fact that the bed is actually in place means a lot of other players that are not sitting in the Ministry of Health. So then they may be looking on that immediate one, while it may not be sort of helpful. Case fatality rate could be a good outcome. So for the long run, absolutely. I don't know, incidence rate, I don't think it will help really, because I'm not dependent on the type of the bed. Referral, mortality rate, that's good, Jana. And Sultana, number of severe cases. Again, I mean, if there is a service, and because most countries establish that, a hotline to sort of identify patients who require bed to be transferred from one hospital to the other. So, okay, so then now let's go back, because we are not trying to solve this issue, we are actually using it as an example. So if you look at it as an example like this, you as a developer of the policy brief start to think of these issues. If I have such a discussion we are having today, I really think it's good to have the monitoring evaluation, some indicators of it, some notion of it in the policy brief, because it requires to be highlighted at this stage. If you end up with something that, I mean, you cannot think of any monitoring evaluation approach, so it's so complex, or remains the policy options at this stage are very vague, it doesn't help you to identify those quite a lot. Activity has not been well defined, or the main outcome cannot be predicted very well. Or if everything is so visible that you think you will be wasting space if you do that, you rather to have it as an attachment, then you don't include it. But if a heated discussion like now, a lot of elements, things that can go, the nice ones are difficult to measure, the data is not there, the other ones that come to mind may not be the right ones. So then it's important to add this into that, into the policy brief. Thanks, Kadis, for excellent engagement in the discussion. So the point is also, as I mentioned, in the organization, that includes also Ministry of Health. Often those in charge of the policy are more interested in the monitoring. I mean, monitoring is immediate. You have ordered or approved the policy. You want to see whether the policy is being followed. So you're more focused on monitoring. Outside, the people and the media usually are interested. So you tell them, oh, I done send so many people there, so many people there. The only what they look at is that whether there was an impact, whether there was someone who needed the bed and they got it, and whether there is further less pressure. By the way, none of us mentioned any indicator related, for example, on pressure on the staff satisfaction. I mean, those who work in the ICU beds. I mean, one of the reasons they have a lot of difficulties that if the bed number is not enough, so that would challenge them quite dramatically. So then the other question I'd like to ask, and I'd like to have, so let's imagine a program that is being properly implemented, and you are monitoring it, and you see that people are doing what they are supposed to do, but it fails at the evaluation stage. Is that possible? Anyone wants to raise hand and share the experience, share the response, and anyone wants to engage in the discussion? 2 participants raised hands. So who do we have? So we have Sultana and Afif. Afif, can you go ahead, please?
Yeah. It is possible, yes. it is possible. This means that your strategy is not appropriate. You are monitoring what you want to do, but I'm not sure if it fails at evaluation. This means what you want to do is not what is needed to be done. This is my answer.
Okay, very good. That's totally true. So Ali, maybe you want to suggest an example. So a real example. Can you?
I just wanted to say, yes, it might happen because you might not, first of all, document. Maybe your example is very good. Whatever you have done, the project is very good, but you haven't documented it properly. So you don't have the documentation. That's the basic part of it. But also it might not be very efficient because you have different criteria, right, for the evaluation. Maybe you haven't looked into different things such as efficiency, such as sustainability. So the program might be very good, but it is not sustainable. For example, it might be, as an example, a good lady health program or a field worker program, but then you cannot sustain it because you don't have adequate funds. You got some funds from the donors, you implement it, but now you cannot sustain it. So that is one reason. And the other reason for failing might be that the initial objectives that you have put for your program, you have achieved those, but actually they are not a very good objectives. So in that sense, you have wasted resources in that sense. Also, it talks to the efficiency to some extent.
So what I wanted to encourage you to do is actually, there is a good comment. I cannot see that chat anymore because I logged out and logged in, but I think it was from Edwina. She had a good example from Lebanon on how a policy that was implemented failed in achieving the objectives. I think, although it was not in the healthcare setting, but that's a possibility to be the case. I can give you a lot of simple work-related examples. Let's say you develop a program to digitalize one of your services, office services, or for example, monitoring program, etc. So you plan it, you do it, it's done. You do it because you want to reduce the sort of time. You want to speed up the process of decision making. But then because of the technical issues that come and go and people not being prepared to use the service very well, or the service doesn't look at all the peculiarities of the details of the work, when on the paperwork you can actually see them and correct them immediately. So then maybe in the medium term, it results actually in failed situation. That is, everything is being implemented according to the plan, but then you don't get the outcome. But they may actually be real examples of sort of failure. One health-related example, which has been documented, is that a country developed a program to help those families that are absolutely poor, on the poverty line, with very low income, to give them direct support. And direct support, food, money, support, and certain subsistence for the use of the family. But they were sure that the program might be corrupted. People who do not need it might come and claim it. So they should set a criteria to look at the the gross level among the children in the family. So that was a program for people who have children under the age of 5. So for sort of younger children in the family. So then the issue was that if they have children that are having low weight for their height and they are not showing enough growth, so then that's a qualification criteria. Later on, some of the policymakers realized some of these very poor families, which were just becoming above the criteria, but they still needed the support that the government was giving. They were keeping one child not very well fed, to be able to continue to claim the program. So a program that is very good and then has been done in terms of the process, but because of badly designed or badly thought of, it doesn't result in success. Or any of, several of the health system programs could become like that. Because the health systems are complex and they have many angles, usually the programs are focusing on one element of the health system, not the other elements. you do something and then you do it well in that element, but then because of other elements, it results in the policy not achieving the objective that it has. So in that sense, it's there. So I'm realizing I'm also probably out of time already. So I go to the final slide. So the other thing, and that's probably the additional point to add here, the selecting the right outcome indicator is really important. Outcome of interest may not be limited to the program, but by that I mean you might be doing something on one element of the program, but the effect of your policy or program might be observed elsewhere. So you may need to look at other indicators that are of attention. I mean, I provide the rule of thumb in here, which is that if your program has a very clear focus, not like the example we had, I mean, increasing ICU beds or increasing maybe increasing ICU beds is the best one, number of ICU beds, then you focus on those clear outcomes of the program itself. If your program has overarching elements, that's the example. Think of the example that we heard earlier about the family medicine program. So then that's a systematic program. It might affect all elements of the health system. So then for that, you need a sort of more overarching approach. So I'll summarize that in the final slide I have in here. So if it's a limited program, program direct objective, cost and effects of the program should be followed. If it's a sort of larger scale program, cost effectiveness of impact on intended outcome of the program, and look at other related programs that might become affected. If it's a major policy that is affecting elements of the health system as a whole, you really need to think widely. So examples, if you're thinking of UAC agenda, health sector reform, you cannot focus on only 1-2 indicators for monitoring evaluation. Let's say if your program is incorporating mental health in PHC, it's a big program, but it's limited in a certain setting. Don't look at only mental health elements. You really need to think of some other important elements of PHC program, because there might be, because incorporating one program into your agenda, the other program might become done worse than before, or it might affect another program, etc. So you need to have some indicator to ensure the program is actually acting on that area. But then if you are thinking of increasing number of hospital beds for a special service, then maybe you focus on the effects of that on that service itself. Okay, then here is the list of some additional sources that I referred to earlier, and some I didn't, but they are not nice things to read. And that's it. So I stop here. Many thanks.